as something crucial. And now I would like to pass the floor to our first speaker, Mr. Marco Renovado from the Integrated and Broad Networks of Healthcare, Mr. Gustavo Rosell from PAHO. Okay, if you allow me to stand up to make our presentation, I will try to present this technical document that we have carried out at PAHO together with many countries and ministries of health and other sectors, because we have launched this document together with IDB and the health community. Next slide, please. This document is based on a 15-year experience and on a previous document, but also in this review of many documents regarding the organization of networks and the integration of services in order to reach the expected results. Please, next slide. This milestone is in response to a context and a reality within our region that in the past 15 years has seen many population changes, and in most of our countries over 10% of our populations are adults, and we have seen also birth rates changing, so that makes us change our policies in order to be able to help meet the needs of our population. We're in a post-pandemic era, and now we have to face some of the consequences of that pandemic. For example, an increase of preventative diseases that we once thought were all under control, and now they are not. And we have also seen an increase in non-transmittable diseases. So our healthcare services must adapt to these new epidemiological situations. And for the first time in human history, we are coexisting among 5 different generations, and therefore we have different ways to communicate and understand healthcare. And therefore our services now must do an effort in order to communicate with these different generations. And also cultural aspects, especially we know that with globalization, we have received information about what is going on in the world. We have news about countries we didn't even know existed, and we get involved with them now. So this is also has consequences in health, because health is not only physical, but we also have psychological and mental health issues that must be taken into account. And all of this impacts our health systems, and our health systems must adapt to these new forms of providing health. For example, as mentioned yesterday, telemedicine, telehealth, broad services. When you see, for example, a treatment for a patient, you have their prescription, but you did not treat them. And then there was one way to act, but today we can interact and talk to patients that we don't even know in person. And that is the new reality we have, and this is the reality that we will advance and will probably even be broadened by the artificial intelligence, and we must adapt to this new context. So all our systems that used to be focused on people, now we have to also train on the community level, because we don't work only in hospitals anymore. Also, technological advancements are very relevant because of the networks, and it's important to take into account. And so we have introduced some important aspects. We have changed some attributes. We have seen that the network is not a topic that is only local, but we have to have national and subnational actors engaging, and maybe other actors that do not work directly with health, but that work with managing social determinants. And it's also important to include the result topics and the adaptation to change, because otherwise we will be talking about networks in the next 15 years and continue to do what we are doing today, but we must adapt. So we have to see not only what we are going to do, but also how we are going to do it. And I think that is very important for our dialogue today. There I have a definition of networks in an updated way, talking about organizations and articulate with these needs in order to meet the population's needs. We're talking about it's not just about diseases, but also the prevention of these diseases and promoting prevention in order to ensure the well-being of the people and not only treatment of disease. And we've been talking about this for at least 48 years, as we've seen yesterday. And after 48 years of this discussion, many of us still do not understand primary health care as a concept and not as just a service provision, because this reflects in the need to adapt and at the healthcare, primary healthcare as a system, as an operation, in order to meet needs and not just a concept. We also brought a definition that this must be comprehensive. The system must be comprehensive because we have it. It has several steps and several services that are provided, and access is crucial in this concept of networks, because we have to go in the direction of universal health care. So when we talk about networks, we're talking about the need of continuity. We cannot have a network if there's no continuity, because the concept of network itself is different modes that are interacting. So people need to satisfy their needs in all along the chain, the provision chain. And services must be focused on the person, on the individual, family, and community, and they must be provided with quality. And so all of this we are bringing to you when we talk about networks that have to be operational and have to be measurable in order for us to evaluate if we are acting as a network, or if we're just talking about administrative networks with only with documentation. And that is not what we want. We don't want to be just a documentation. We need efforts it's for integration and for people to identify with this network and operate as a network and to work jointly and together. And that is it goes beyond any administrative operation. And that is important because we cannot work in a fragmented way in a network. When we're talking about health programs, we know that there are countries that have over 14 or 20 vertical programs with their own planning and management and financing mechanisms. But they must be integrated and coordinated in the service provision part, at least. And that is why we're giving this relevance to the integration of programs and the interventions in public health and the intervention of the management of social determinants. These are all elements that determine 4 realms. And please, next slide. So here in realm 1, or domain 1, we know of our organization of attention with a focus on a territorial health care. And in this domain, we have 4 attributes. The first one is that in order to design the network, it is established in a territory. And on this territory, the population is the most important factor. But not only the population living there, but also those that carry out their activities there, children who study there. That is the whole dynamic of the land, of the territory, which is done not only by the people who live there. And these people also have different characteristics, social characteristics, cultural, and different needs. So the first point is to learn about this population. Not only know how many people live there, but what are their names and what are their needs. And this is what we did in this visit in the center. We talked to each person. We learned about their vaccination status and their health, and that is the kind of information and knowledge that we need. So in order to establish this kind of health provision, focusing on people, family, and community, we designed all of this. So when you have when you know what are what's the care that is needed for this population, we generate the mechanisms of coordination since the families, because the caretakers are the families. We take care of ourselves within the family, and then we start creating this relationship with the multidisciplinary teams that are formed in order to advance the process. It's not just the process regarding disease, because when we're talking about health, we usually make this analogy, this relation with disease. We are actually talking about comprehensive health. So the next step is to provide the services that are needed for this care. We're doing this within the institution, but also outside the institutions. We had this health care centers for mental health in these communities for teenagers, because a teenager is not going to a third level psychiatric hospital because of anxiety, which is a very acute and serious problem we see within teenagers when they're moving on to their college years or even into the workplace. So how do we meet the needs of these people? That is one of the proposals of this network system. In the second domain, we're talking about the comprehensive management of all services, especially for direct care, healthcare, but also support of these services. Also, structure and equipment have a very important role, but we're not talking about building big hospitals or very specialized treatments, which is needed, but is not enough. We must reinforce the primary healthcare with technologies that is available and that can be adapted to those needs. And many times they are mobile technologies that we can take services to the population that is most vulnerable or at risk. On the other hand, it's also important to have the HR management, and we're going to talk about this and what are the competencies that are needed, but not only the professional competencies that are learned in the university to treat diseases, but what are the competencies that are needed to take health to the people. These are soft competencies because people have to trust us. They have to do what we tell them to do. And according to many studies, nearly 60% of people that leave a doctor's consultation do not follow their directions. And that is big because the system is making a great effort to provide services, but many people do not follow the instructions, the doctor's orders. So there's an example of this problem regarding trust, efficiency, and reliability. Now the medicine management, drug management is also, we have to give access to these drugs, but if there is no access, then we won't have an efficient result. So this is all these interventions and action plans are also important and also rely on technology. Management of support systems, the reference and counter reference, the articulation, for example, the pre-hospital, the clinic care. It's also important in order to bring the support closer to where it is needed. And lastly, the management of digital transformation. Yesterday we had a very interesting panel on that. Today we're not going to advance on this if we do not have a digital transformation. As Gabriel told us yesterday, we need to have mobile the information anywhere we go, and it should be easy to access, no, regardless of where we are. We shouldn't have any bureaucratic barriers because, for example, if I'm from one insurance company, if I'm insured in one company, I cannot be treated if that insurance company doesn't cover that place. So there's a lot of bureaucracy that has to be overcome. So this is a normative problem, but also is relates to how we use these networks and articulation. The third domain is related to governance and social participation and intersectorial action. Governance that we propose is a multi-level governance, that it's not on the medium level or on the network management, but it must be articulated through the different levels, national, subnational, and local level, in order to seek solutions to problems and also to participate in the decision-making process within this governance. Then we have the management. And so the manager of the network is not a manager of a hospital or a healthcare manager. It's a territorial manager. And therefore, they must have this kind of relationship with the different kinds of actors in order for health to really become the responsibility of Bajo, as we say, of course, but of the different social actors. They all must have this responsibility, and that is very important within the management. Also, effective social participation is important because we have to understand how people will participate in the networks and what are the results that we expect with this participation of the population. That it could be in planning, for example, but also it could be development of children or in their experiences in networks. We're working with parents. We were able to reduce anemia with nutrition because it's the families, the parents are the ones who live with the child and feed them, not the healthcare providers. So that is why in this network, social participation is very important. The next part is managing results, to management based on results, because we have to organize, but we also have to see results in the population's health with their own participation. Then the next is that for that we need an information system, we need data, we need processes, and we need to mitigate risks. We have to try to prevent problems and not delayed, because we have many problems that can be prevented, and others that for which we cannot be prevented, but we have to be prepared for. Lastly, we have the management of change, because these proposals, these discussions should not be just an action which we begin with much enthusiasm, but then we go back to doing things the same way we always did. We are usually say, oh, we have networks in countries, but it's still fragmented. We need many years for them to become operational because we have taken this organization action as something secondary and not as something really important and relevant for us to change the way we meet people's needs. And the fourth domain is related to resources, to financing, that are very important. And here we're talking about three attributes. Must be enough. The financing credit must be enough. We're talking about the allocation of resources and payment systems according to the needs. We have to be very rational in the allocation of these resources, not do everything as we always did historically, but if we allocate resources well, we'll have better results. And also investment to develop the networks in the primary health. So from this point of view, we're trying to guide that these resources are needed. We know that hospitals need financing, they need money, but also the primary healthcare level also needs resources, not only the hospital. So this is what we're talking about. Here you can see the conclusions about that the network doesn't work alone regarding financing. We also need the engagement of ministries of finance and economy, also National Congress, deputies, And I have only 4 conclusions. The first one that is important regarding networks is that networks allow to overcome fragmentation problems. And we have seen this in many institutions, and we are convinced that this is the way things should be. The second is that attributes answer to contemporary challenges. The problems we are facing now are different than those that we faced 15 or 48 years ago, but strategies may be similar. For example, strengthening human resources is something that still works, and we have to engage universities and training centers. Since this is an issue that we're going to continue talking about in the next panels. We also have a flexible framework and an adaptable framework. You have to take all of these elements and to organize your networks in order for them to be useful in to respond to the population's needs. So this document must identify these elements that will help improve the integration, the comprehensive and the continuity of healthcare. And lastly, in this document is a call to action in an institutional and cultural way. It's to mobilize political and cultural movements, cultural within even the workers themselves, because sometimes we do not identify as a network. We are identify only with a specific institution. We don't know how to work and operate as a network. And this goes beyond the administrative issues. It's communication, it's operation. We do not feel as part of something larger, but we need to give a more holistic and comprehensive response to our patients. Thank you very much.
Thank you very much, Gustavo. I'll give the floor now to Marcia Gomes from the World Bank to talk about the network. Good morning, everyone in the audience and those in the virtual channels. Good morning. I would like to thank PAHO for organizing this important dialogue. Dr. Gustavo talked about the updating of this framework of healthcare and what it represents. It's a guideline to strengthen the health systems, to have more integration, equity, emphasizing PHC as a fundamental cornerstone. In this concept, those networks are a model that integrate the actions in general to guarantee continuity, so we have more efficient healthcare systems. So this consensus creates an honest language among the governments and the banks who are our partners, and consolidates a shared view to consolidate the healthcare systems in the Americas. So this framework is very important to society and the healthcare system. And we know that a network, RIIS, doesn't mean that we have everything in a certain place. The real integration of all the points of attention demands changes, and major changes everywhere. From the point of view of multilateral banks, we know that those changes are going to be implemented little by little. We have to adapt and respect the political and social climate of each country. A transformation as big as that goes beyond the technical aspects. What we need is political decisions. We need a strong PHC that is a real access and not a symbolic one of those networks. And we need systemic changes that are sustainable in the long run. So we don't have just one and only model to implement these concepts. One of the most important aspects to update the landmark of RIIS is the advancement of practical orientations. Concepts become actions. Then we can incorporate this framework to the projects and other ways of collaboration. An example could be our projects on those networks collaborating with subnational and national governments. They represent some of the pillars of this major transformation in the health systems that are organized in networks. We have 4 axes that are present in all our projects. First, all the investments in infrastructure, services, and technology should be clearly inserted in the logical of networks. There's nothing we can finance without transparency. It must be linked to PHCs and it must be integrated to the services. Secondly, we must have the software of the networks, strengthening new competencies about management of networks and the creation and consolidation of governance structures, the spending of capacities via legal changes, development and capacity building in care lines and new organizations. Third, we have to support digital transformation. More access to services. We have to reduce inequalities via IT systems that are integrated. And this is critical to guarantee a continuous change in these networks. And last but not least, we have to focus systemic results. We have to evaluate and the financial fostering change from physical places to effective results that will reduce inequalities. And my final message would be the fact that we want to have resilient health systems if we don't have a real integration of services, and a multilateral financing can be a catalyst for this transformation. Thank you very much. Now I'll give the floor to Mrs. Batista from the Dominican Republic. Good morning. How are you today? It's a pleasure to be here again. I see new people here, and it's good that you are here. The main challenge in my country is the consolidation of the networks of healthcare, is to overcome the structural fragmentation of the system. We inherited a model that was centered in hospitals. We have just started the networks. It's an instrument that was suggested to us by PAHO. We can say that we have 5 levels and we are in the middle of implementing them. There are gaps. There is an important one that we have to overcome. That is the gap of primary health care. In my country, we have a service rendering companies, and we have 1,800 establishments that are near to universalizing the healthcare system in my country. 57% are within the subsidies that we receive from the private sector and the public sector, who are our partners. So, added to that, we have the challenge of the inequalities that our society have, mainly in the rural areas, the remote areas, especially in the south of my country, where we have less development and people are more vulnerable. So we need, we have also hospitals, but the sustainability of the networks are still a problem, a financial problem. We have financing systems that are not enough to sustain our networks. We know that 30% of our budget should be destined to primary health care. We are getting there. Now, due to political will, the president was very clear saying that the primary health care is a priority of his government. To strengthen PHC is one of his priorities. So we have 30% of our budget, but we have that via instruments that the Alliance, the IBD, and also the World Bank help us to strengthen the structure that we have, to establish new processes, and also primary health care is a priority in our country today. Another critical challenge is the transformation of the fragmentation that we have nowadays. We have the lack of a system and the infrastructure in terms of digital healthcare. So we have to establish a challenge that sometimes we have infrastructure and the gap that we have in the use of the digital healthcare in the remote areas and the ones that are less developed. So we have the system that is still a gap that restricts the coordination of the clinical care. And finally, the social participation. We have to strengthen them so that we can consolidate networks that are really useful and get to the right people. Now we give the floor to the Brazilian representative, Mr. Cesar Neves. He is adjunct secretary of the State Secretariat of Paraná. Good morning, everybody. I would like to acknowledge Dr. Rodrigo Oliveira and my colleagues of the panel. And I would like to thank for inviting me to be here. And our local regional realities in the Americas, although they are very unique, we are united in difficulties and also in solutions that can be carried out by everybody in the continent. My state, Paraná, is a state where we have 12 million inhabitants. We have 399 municipalities, and we have to face major challenges. In the health map, we have 22 regionals of healthcare and 4 macro ones. And in our capital, Curitiba, we have one of the best HDI in the country, like if it were an European country. But we also have fragile areas, especially in the case of accessing medicine. So the pandemic have taught us a lot. Among those lessons is to reinforce the investments in primary health care, not only because it is the mother of other cares, but mainly because it's prophylactic. We must have prevention public policies. It's our 8th year of our mandate, is the last one for our government, and we have invested more than 2 billion reais in primary health care. Not only state programs like Paranaense Mother, mental health programs, and mainly in partnerships. Partnerships with the Ministry of Health, with CONASEMS, CONARS, the PROADSI program that is from the Ministry of Health, bringing qualification and also excellent hospitals from the country, training professionals for primary health care. We also opted for having digital health. We have a PI of digital health. We are supported by several benchmarks, and we realize that digital health focused on PHC is an important driver to relieve inequalities and mainly to understand the different regions of health with their own characteristics. Our PI is called Digital Health Paraná. In real time, we have indicators about vaccination, consultations of prenatal, IDCF, the health of the elderly, and as a state, we are able to support the 399 municipalities, monitoring them in terms of their vulnerabilities, and we make those policies, mainly the policies that deal with community health agents. We are able to maintain levels of policies of prevention and vaccinations that are always very high. So we have a daily challenge, but we see that if we didn't invest in networks and mainly in regionalization and tripartite partnerships, the federal government, the state government, and the municipal governments, the challenges would have been even greater and even more difficult to be met. Recently, the Ministry of Health has launched the program that says, now we have experts. It's a national policy of specialized healthcare, but it has an open dialogue with PHC. There are no policies that don't dialogue, that don't talk to one another. We have been very successful in decreasing inequalities, mainly in our regions, and mainly we respect this tripartite system that we have created because we don't have enough resources. But if we have this system with three offices involved, we were able to meet results and demands that were very successful. And we have health care to each inhabitant of our state. Thank you very much. Thank you, Cesar. Now we are going to listen to our fellow from Argentina.
Good morning, everyone. Thank you for the invitation. I'll have an active presentation, and in order to share a few items that have already been mentioned, I'm going to use two variables. The first one is time, and the second is the variable place. Next slide, please. Oops. Next one, please. There it is. Next. Okay, so this is just to show you this graph that came from a PhD student. It's from the that is better known as for you as the city of Mar del Plata. Here we see 23 years of democracy in Argentina, and this is one of the issues that we use when we analyze time. We have here the time and the territory regarding the general population and the food and nutrition policies. You can see the lack of coherent points or consistent points that can make us believe that there was a concrete and established policy a long time. And this is also one of the points that translates as everything that regards healthcare services. Here we can see a difference regarding the coverage of age ranges, and here are the goals: fragmentation, segmentation, and because we are talking about networks, we try to compare it with complex systems. These systems that represent this in the territories with which oftentimes, and we are trained in different universities and medical schools, it's done fragmented. We have different categories, and the results afterwards, we try to demand that they have a thought or a integrated view. We began working with the different universities and medical schools, first of all changing the role of scientific societies and including the roles of advisors and different commissions of these medical schools, because behind all of this there are interests and particular power struggles and interests of certain individuals. And I thought it was very convenient to show this graph that we did it in the beginning of last year, which is the map of coverage. And here also one of our concerns was mentioned. This is a coverage map of vaccinations in Argentina, especially those that are in our calendar and that we purchase and distribute. These are the 18 vaccines, but also those that are distributed along the territory. And what we did was to put all of this on a map, and we began to analyze what are the ones in red or yellow. The ones are in red are the ones that demand more responsibility, but we are also working with what yesterday Rio de Janeiro has shown us, which is monitoring. And the evaluation point regarding territoriality is that the Ministry of Health in Argentina is the manager, because the different provinces had not delegated health or education to the national government. So what we do is give them a toolkit and do what the law mandates, but we also try to explore what are the points that generate more gaps. And that is why I also think that the definition of the operation of networks must be done on the territorial level, and that is where we have the first level, but also all the factors that are related to not only prevention, but also looking towards the other side in looking at promotion of health and analyzing what are the factors that are more preponderant. Oftentimes the Alma Ata talked about the water management and water provision, and that is something that we seem to have forgotten, and that is where we're also putting our emphasis in order to generate the environments that are possible and that also are impacted by political pressure, and this happens in also on the province level. But we have talked to several media outlets and journalists, and they asked us to consider citizenship. And that is why we are making some adaptations, because this is a very complex process, but we also believe that it should be shared and we must assume our responsibilities as the citizens. And this is a topic that is very complex, and also we face many challenges, especially coming from the anti-vax movements. And that's what I had to present to you, and I we are like to say that we are very worried, and recalling what the Greek used to say. You have the two goddesses Ihe and Panacea, and in these times Panacea has been winning the battle because she dedicates to uh, cure disease than Ichea, who is the goddess of hygiene with water that gives us health. So thank you very much.
Marcela Quadrado, por favor. Oh, acho que eu troquei a ordem. Estava indo tão bem. Vou então passar para a diretora de Atenção Primária de Saúde de Cuba, Yagen Pomares. Me desculpe.
Okay, now let's pass the floor to our representative from Cuba. Thank you very much. I would like to thank Pajo for giving us the opportunity to be here sharing all of this with you and sharing our experience in Cuba and sharing this. And also would like to thank the Ministry of Health of Brazil, because Rio de Janeiro is a great place to host this event, and it's a great joy to be here with these excellent professionals from different countries, and we are all sharing what we are doing, but maybe some have different focuses, but in this meeting we have been showing what we do, and we are making it very clear that we have many challenges to face, and that we also must focus on that in our countries. So this is my presentation with our focus given to primary health in Cuba as a nucleus of a comprehensive network and a regionalized network. Cuba has very unique characteristics and complex situations that many of you already know, but we are still motivated and excited and to defend our health system that is unique and has specific principles that characterize it, and I'm sure that oftentimes also differentiates it. It is a system that is characterized by universal coverage, and it is available and comprehensive. And about integration, I'm going to talk on later on, but it's also equitative and regionalized. And as we said, it is organized on three care levels. And the first one has two basic steps. One is where we have the 10,500 medical family physician offices. It's a structure that has that covers 1,000 and 1,500 families of people. On the second step, we have 451 polyclinics in all our municipalities, and that today are being reinforced. We need with 20 specialties that I will comment on later on the operation. At second level is where we have the 151 hospitals, and then we have a third level where we have 12 institutions. However, when I'm going to talk about integration and share some criteria, we also face a great challenge regarding all of this. But what we want to we manage this in a different way, and that is why we have seen a difference between integration and fragmentation, and that is what we want to talk about dialectics. And this is a continuous process, and it's a process in which we have the continuous improvement in the process as well. But this integration in Cuba that we always defend and share with you, it has this territorial focus. And when we talk about this, we have four dimensions: governance, and here that has been commented here since yesterday, and how governance is considered as fundamental for intersectoriality. And when we talk about governance and how Cuba works, although whole integration of governance, in the Ministry of Public Health coordinates through the authority over other ministries, and that is why it is able to develop several interinstitutional and interministerial agreements, for example, with the Education Ministry for training and for youth, the Labor and for Social Security Ministry is also a partner, and we're always talking about other institutions in which health plays a crucial role. And we're talking also about governance and levels and the roles in the different territories. We have different departments and health departments that are on the provincial level and municipal level managing everything that is related to governance. And that is why this intersectoriality is important for solutions to primary healthcare as a strategy and governance, especially on the first level. Now, financing for health. In Cuba, we have a national budget in which we have allocated institutional budgets, but also an important challenge that we are facing today is related to the wages for professionals. And we are recovering different incentives and aspects that allow us to improve this specific topic. Then we have the training of HR. Last night I was thinking about this and how we in our country have this uniqueness that all the training of our professional is under the responsibility of the public health ministry. Our universities are ours, and graduation, postgraduate degrees. We have this training that is focused on services in which the primary health and all our institutions of primary health play a crucial role in training our professionals. And finally, the service provider is the person that is responsible for ensuring health care. And here we have all the municipal departments, everything that is related to service provision and integration. And we will also talk about that integration has to be done, and the challenge is in ensuring training, recruitment, incentives, health care, but also research. Research plays a crucial role. Today, our first level of healthcare is allocating and contributing with clinical trials and research to help this scenario. So in Cuba, primary health is a state policy, and its access of continuous transformation of the national health system is seen as such. And one of our most important achievements for our strategy Health for All in Cuba has been the prioritization of primary health in Cuba, and this translates through the physician program and the family nursing program that focuses on the integral attention to the patient, the family, and the community. And then why do we talk about the essential attributes of primary health? In Cuba, we are also focused on these essential attributes in order to continue improving primary health care. First of all, because we are defending that primary health care is the entry door to the people, because people go directly to their family physician. Like we said, we had 1,500 people that go to these family physicians or nurses, and that organize and update the treatment or the following of this patient for a year, or we can then analyze if the patient is healthy or has some risk or anything. Longitudinality and continuity and proactiveness is not a secret. It's this relation that we have to have. It's constant, permanent, and prolonged. For example, 2024 was a year of many transformations in order to seek alternatives, how to continue to defend doctors and nurses to have a coverage of not over 1,500 people. Integrality, we know that the family physicians and nurses that they're in their community in which they manage their whole care, they must also manage and do the coordination and the logical articulation, which is another great challenge. We have references after references, and we face the same challenges that other countries do, and this is something that in Cuba we must continue. Even if we have a very well-designed structure in the operational level, we still have much to do and improve. These are the first level of healthcare institutions, and I emphasize that through our family physician and nurse program has a principle, the promotion of health, the prevention of diseases, and the rehabilitation. And we do this through different aspects. One of them is that we've been thinking for some time and putting in our agenda is how can we achieve a more resolution-driven for primary health care. We have 451 polyclinics, and we on the first level. And these are now in a second level of healthcare, and they have 20 specialties like neurology, surgery, pediatrics, 20 specialties that make this service closer and more specialized in treating the patients in this level of healthcare. But we also have 123 municipal intensive areas with different kinds in these 123 we have more intensive areas, and this is part of the regionalization. In each of the provinces we have at least one that answers to this kind of healthcare. We have 423 rehabilitation offices. Cuba has 168 municipalities, so when we look at these numbers, you can understand that at least there is one kind of service in each of them. And we have 175 municipal mental health units, and this is just for you. This is a very particular idea in Cuba. That is where we can have this coverage very close to the community. We have also care for pregnant women, and we have old people's homes. And all of this is part of our arsenal from the polyclinics, and this is services we can provide, and we are investing in expanding all of the resolution on our primary healthcare system. These are numbers from 2025. We have physicians, nurses, and medical students, and in different specialties. And just to conclude, here you can see some aspects that might seem like disorganized ideas, but it's just a summary of what I wanted to share with you. We're working on resolution, and the specialties on the first level of care gave us a very important idea. The comprehensive networks are based on territoriality. We have a unique system that is integrated, that we continue to defend, that is ready to answer disasters and catastrophes. And COVID taught us a lot about that, because we all played a very important role in resolving problems, not only in the hospitals, but also in treating COVID patients in PHC on the first level of care. The integration of medical staff and medicine is very challenging, because we have to manage production and distribution, and we are impacted. Also, community participation has a fundamental role. Intersectoriality and the interaction of technological resources for diagnostics, and that is why we say that PHC also demands some kind of specialization to some extent because of this. The integration and training and communications are also important. We talk about promoting health and treating disease, and all that needs the communication strategy. And then the integration of science, research, and innovation must be a strategic pillar for Cuba. And that is why we say that PHC in Cuba is a state policy. It's not just a level of care. It's an operational logic of a universal healthcare system, and that prioritizes being close to the patient and continuity. And that is very important for us at these times. Thank you very much.
Now we have the representative from Uruguay, Marcela Cuadrado. I'd like to say hello to everybody in the panel, and I would like to thank you for inviting me to be here representing my country. I would like to say that the organization of this event has been very well carried out. To Uruguay, we are going to integrate this alliance. We are going to receive our minister, and tomorrow it's going to be signed. We are part of the commission of this attention, and I'm very happy that PHC is the central theme of this conference. What I'm going to present is the articulation of public and private service renderers in our health system. In Uruguay, we have been doing that since 2007, when we created the law of the integrated healthcare system. I represent ACE, that is the public service rendered in the health area, that is the biggest in Uruguay. According to the law, since 2007, we are decentralized from the Ministry of Public Health in Uruguay, because the ministry doesn't render service or health care, but we represent them. ACE is a key actor in the area because it's the biggest service render in terms of health that we have in Uruguay. So we provide health care for half of our population, and we provide services for 41%, more than 41% of the population of the country. We have a public role as a service provider of health that is a major one, and it's part of the National Comprehensive Service of Health, as I told you. This Comprehensive National Health Service started via the law 18211. This is the structural framework in terms of health and public services, and because it is integrated, it's comprehensive. We have public service providers and private ones. We have small pharmacies that are in the interior of the country that are part of the system also, but we have private service providers, but they receive public monies also, although they are private. So within the Ministry of Health, what we do is to regulate the service providers of health. There is an articulation of both the public and private service providers. And this articulation is very important because we know that we have fragmented systems, as everybody has mentioned. We have inequality, we have scarcity of resources, we have difficulty in continuous health providing. For instance, a mother has a baby in the private sector and then goes to the public service, and so it's difficult to have a continuity of healthcare. This follow-up, this continuation is difficult. We can talk about networks of healthcare, and this generates duplication, redundancy, and inequality. But we need this articulation to guarantee the right to health to the whole population. So why do we talk about articulation, and why do we have to talk about public-private articulation? It's not a goal in itself, but it's regulated by the law to guarantee access, continuity, and equity in the health services. What is the role of ACE in the articulation? As we are the main service provider in the health area, and we are present in all the national territory, we have 35 units of second level and more than 800 units of primary health care. So we have to articulate and integrate the continuity of service providing in the health area. We have partnerships, we have ways of working that can be multiplied so that we can provide health care. We are a small country. We have 3.5 million inhabitants. Most of the people are in the urban areas. We have a small portion of the population in the rural areas, and they are the most vulnerable. What is the goal of the system? The Ministry of Public Health is the controller of the enforcement of the public policies in this area. Without a control, there is no integration. No integrated system works without governance. So that's the main role of our institution. As I told you, we have a financing for the system via FUNASA. That is a system that I'm not going to explain now because it's not so interesting for this forum. But within the law, it has been written, the National Joint of Health, where we articulate the health policies, the different service providers, and the changes in this service. We have all the problems stated there. Under the law, JUNA is in charge of the healthcare system and also the strategies in the health area to the whole population. We have representatives from the Ministry of Public Health, representatives from the Ministry of Finance, representatives from ACE and from the bank. We have representatives from the workers, public and private workers in the health area. And we have also representatives from the state. So it is a board, it is a team where we can sit around a table and discuss the health problems, the health policies, and the difficulties in providing health services in the country, and also the users are represented in this board. So what do I mean when I say that we have to articulate, integrate, working for healthcare? What I think is important in this slide is the fact that there is no strong primary health care without integration, and there is no integration without the guideline of the state. articulation is not a concession amongst the service providers. It's a policy of the state to guarantee equity and the right to health in all our territory. Integration is not something that you put in a decree. You build it little by little every day. And primary health care in the country is worked with the people, with local and municipal boards or teams of health care. We must have the one at national level and the local one so that we can build together health in the whole country, or a strong health system. Thank you. I'd like to thank you, Marcela, and all the panelists. It's very impressive to see that although each case is unique, we have drivers that are similar in all countries, and also challenges that are present in all programs. We have a sort of half an hour still, so I can open the floor to the audience. I would like to open the floor for 3 questions. Let's say. So before you ask your question, present yourself. I am Francisco Campos. I work for Fiocruz and Unasus in Brazil. And I've been working for PAHO for a long time, both in Washington and also in Brazil. We discuss the aspects of international cooperation should be taken into consideration. And I would like to say that in Brazil, we have primary health care that is reasonably organized. And if it weren't the participation from our brothers from Cuba, we wouldn't have arrived at the situation we are in. We had 1/3 of the jobs of family clinics without doctors. We had a fascist genocide government, and this government really terminated with this proposal, and then we had to recruit people from Cuba, and many Brazilians only saw one doctor in their lifespan, and they were Cuban doctors. I think this is very important because the Brazilian population miss those Cuban doctors. They think about those doctors because they know that they helped them. They were the only doctors that they were able to access. So you have a good system in Cuba, but the cooperation that you had with Brazil was really essential for us. And I have to say that PAHO was a major actor because it was a decision by President Lula and Minister Padilha, and also the director Clarissa Etienne. And I myself know how we were criticized for supporting this program. But if we didn't have that, we wouldn't have had the way of going on with other experts like Rodrigo from the Ministry of Health. Thank you very much for listening to me. I am Pedro Lopes from PAHO in the Dominican Republic. I have a comment and 2 questions. The comment has to be with how you have to measure the evidences, the proposals, and the proposals of implementation. There is a process of renovation, of renewal, to integrate the networks in terms of concept and operation. I think the time has come to start a process of how to measure that. How do we go on with integration? We cannot evolve if we don't measure. It's important we have strategies of generating integration, and we have to measure that. Secondly, we have to measure the impact of the networks that are in the process of integration. We have to show the impact they have on the population, the capacity of access, so that we can compare with the present with the past. And I have a question. We know there is a building process of a network, a regional network, so that we have a better network of services. This process of a network, a regional network, how is it going? What would be the future goals of this network? And what is the role of the teams or the boards of integrated healthcare in the different regions? We can have one or two more questions. Three, and that's it. 3 questions more. Good morning. I am from Goiás in Brazil. And when we think about a healthcare network that is coordinated and organized, and what is the role of regionalization, we find some challenges that are common to all countries. The high turnover of professionals, programs that are successful but are discontinued, resistance in some places to hire health community agents, the lack of engagement. Sometimes the PHC is not believed in, and the social participation is very small. There are some biases that are marked by conflict of interest. Many times we are wrong because we think that we know what the population needs. So when we face those challenges, I know there is no one answer for this question. I would like to hear your experience in your countries facing these challenges. What would be the main strategy so that PHC can really have a major role within the network of urgencies and emergencies? Good morning. I am Brazilian, but I'll try to speak Spanish. I work with the Minister of Health. In my question, before asking a question, I would like to thank you for your contribution, for your different opinions and technologies, and so many things that we can exchange among our countries, and different perspectives of a good primary health care with lots of advances and new technologies for a world that needs it. I paid very close attention to what you all have said, and I realized that the social control, that social participation, both in Cuba with the CDLs, has a role that is important and similar to the one of Brazil. So social participation, although there are many problems, I think that social participation is paramount for primary health care, because the people can participate and the people can talk to the government and have an open dialogue. So my question is the following: what are the perspectives in your countries in terms of social control? I would like to know if you have any experience, if you have thought about that, and how does it happen, let's say, in your countries, this social participation? Good morning. I work for PAHO Mexico. My question is, first I would like to thank you for your presentations. My question is for about the integration of the networks, the reference and counter reference. How are you working with that? Do you use digital technology? Or what are the challenges that you face in this process that deals with integration? So I'm going to give the floor now to comments and answers from our panelists, following the order that you spoke. 5 minutes for each one, please. Thank you for your questions. So we can then talk about what we have been doing in the regional healthcare. And we have local and regional responses that can contribute to other countries. We have this initiative of the network that drives the other networks. I have our president from Uruguay, Marcela Quadrado, and our vice president from the Dominican Republic. And it's a coincidence that we are in the same panel. In terms of goal, this year we have 4 teams where we establish some developments to strengthen the continuity of our work. And as we have said, we have those teams that we call mesas, and we need financing and governance in each territory. So this year, we are going to come from evidence to practice in different sectors to be operative, so we can deliver development, and so we can accelerate what we are doing. As about the evaluation of what has been done, PAHO can do that. Are the tools of evaluation. We do have them. It's very important to have an evaluation of the programs, because we have different populations that are fragmented with different needs. So we have to structure a system of evaluation that allows us to plan for the future. So I believe that this will help so that we can really meet our concrete goals. And that's it. Thank you.
Thank you very much for your questions. I'm also eager to listen to my colleagues, but from the point of view of the IDB, I would like to reinforce what Dr. Gustavo said about the information systems. Our colleague asked about this and the possibility of evaluating the performance of the networks and the levels of care. This is really a task for us to keep in mind for the future. And as a bank here in Brazil, we are also supporting states and municipalities to develop systems that may capture these aspects, that encompass these captures. Because when we look at our data bases and systems, when we have long historic series, and we should be based on them, because our systems are reporting production. And I think we should have a shift, an important shift, from a management view to combine these available information and really build an indicator panel from the official indicators that will give us the possibility to measure this integration. Yesterday, Dr. Sorans presented a very important aspect of the monitoring in Rio de Janeiro, capturing the longitudinality aspect of care and the continuity of the staff regarding the user or patient. And that means that we must take two steps back in order for us to understand that we need robust information systems that are operable. And this is an important bottleneck that we have to make efforts to overcome in the next years, because we have to make these systems be interoperable, and this micro data must reach the decision making levels. So these are promising aspects for us in the future, and that dialogue, the alliances, thematic boards and tables, because it's part of discussing this regional panel to know about the capture of information and the dialogue among initiatives from PAHO and IDB. And I'm going to then the name is La Ruta de Transformación Digital, which is the digital transformation route, is the name of the project that puts all the countries on the same path, and how to continue together, and how we can compare the advancements among countries. Thank you very much. Thank you very much. As Gustavo mentioned, together with Marcela, we occupy the vice presidency of the network of the board of networks, and we want to elevate the level of the alliance towards an international cooperation where we can exchange experiences and learn about how each country has advanced regarding the articulation of its networks, regarding the primary health as the entry door access. And about the social participation at the Dominican Republic, we have two ways of dealing with this. The first is roundtables, working roundtables, where we have the society, the academia, and many ways of expression. But in the Ministry of Health in our country has 42 provincial departments for health, and each of these departments are the ministry on the territory where they are located, and then in a way they are the ones who articulate with the municipality and the communities and territory, not only on the state level, but also with civil society. They are listeners. And as we have created what we call like a vice ministry that is concentrated, that serves the whole territoriality and elevates technically and in an institutional manner the sectoral to the sectorial parts, what we listen and what hear and receive from these territories. I'd like to answer our colleague from Goiás who asked about the policies. Please send a hug and greetings to our secretary in Goiás, and I also like to greet another Mr. Rashida here. But we, in this context of reinforcing primary health care, we must think about using digital tools. This is essential. Not only the issue of the BI that monitors indicators in quantitative way, but also in regards with quality. And this way you can ask of municipalities and their managers their indicators regarding vaccination or programs for diabetes and high blood pressure and the elderly, but also use, especially in the farthest regions, you can use telemedicine. And that helps you, because when you have that within the health culture of the population, this goes beyond governments, because it's when you have a government that has this kind of program, they will not change it, because it's an achievement for the population. So that is very important to have in mind. And something else I would like to emphasize is during the COVID pandemic, We cannot talk about successes when we lost so many lives. However, we never deviated from science. We kept the path of science. We we always promoted vaccination. We defended the vaccine with the support of the Ministry of Health, our states and municipalities. We were able to reverse the low vaccination coverage. And these are gains for the population in a very Republican and transparent way. And probably no one will take that away from them or change it, because once you have health assured, then it's insane to take that away from the population.
I have 2 or 3 points to mention. In Argentina, I come from a generalist. I am a generalist in a province in the north of Argentina, Cucuy, and I have the experience of Alvarado in Cucuy, which is the sanitary or health agents. So what are the points that I would like to highlight to answer your questions? The Ministry of Health in my country went through fragmentation also because we had problems of databases for professionals and for the facilities. And we started to discuss that to obtain consistent data, and so we could start implementing the program. And we have meetings every month with all the ministers from all the provinces so that we talk about our work lines and what we are going to have as our goals within the Ministry of Health. Because culturally, we had vertical programs, but the dynamics of this verticality would prevent us from having a transversal dialogue. Only with a dialogue that is horizontal, we can have a better ministry where we don't have isolated work groups or different agencies that don't talk to one another. We also configure information like the 10th of December last year. We had a census for health care, and we have many challenges, and we are working together with the Population Fund, and we also are working in lines of health care. With this process, we selected 90 pathologies, and we are doing our work with the provinces, and it's being updated right now. And there is an issue that also is the financing. Each province has its own budget, its own economy. So we are the managers, and then we have the process, then we think about money and prices. On the other hand, we also had a key point that is a system of dialogue with the economy, with education, with human capital, with all the points that were mentioned here, also safety and security. And as for the economy or financing, I think that when you go to a negotiation table, everybody says there is no money. Because of that, one of the things we work with are medicines that are high-price medicines. We have an experience with the Novartis laboratory where we have a risk contract. And in the papers that were mentioned, that we didn't see that, and we didn't pay the laboratory. And we then were able to have the financing, and the laboratory decided to work with us and renegotiate our debt with them. So it shows the efficiency. If the price is too high, it's difficult for us to do business with them. And as for the participation, each of the ministers can decide about his or her own territory. Of course, following the guidelines and maintaining the commitments that we have, both at local level and international level. Another challenge is the fact that you can have the most data that you can have, so that you have a better decision-making process. Another important point that has been mentioned is the gaps that we have in terms of perception. When you see that there is a change in a territory and you understand what is going on, you can talk to us. Those are that's why we have the health promoters and the health assistants that we have. Also, they should be heard. We don't want to have only numbers as indicators. We have qualitative indicators, because this is a major challenge. Those are the points of the things that we have been doing in Argentina. First of all, I'd like to thank you for your questions from Brazil, the comment from Brazil, and our experience in Brazil as Cubans was very good too. As to what we have, we know the moments that Cuba went through in the services of health, and we talked to PAHO as the position that we have to update all the process that we have. So everything that we have been showing, we can share with the evaluation of indicators and how the processes are going on. And Cuba is going to be part of that this year. And we have this as a priority, to incorporate an evaluation process for the networks and for the role of the participation of the community. This is very important, but it's a challenge. We believe that we can use several different resources, mainly the municipalities and the community participate in the health area. So we want to act. In the last few years, we are revitalizing this process. It is a moment of community participation, a real participation. The population can say what they need in an active way. And we are not working on the person or over the person, but with the person for primary health care and the promotion of health and the prevention. We have very interesting niches. Different populations have different needs, but they really can participate. From the surgery of the doctor in the family clinic, we have an analysis process. It's a document that characterizes the population in all their spectrum. You characterize each person and you discuss in the end with the community to say what happened, so that we can prioritize having in mind the real problems. There are problems that we can't solve with a doctor or a nurse, because the problem is bigger than that. But I think that by exercising this participation every year, it is improved little by little. What about the popular control? It's one of the areas where we can do something at the level of the community. I was the general director of healthcare in a small municipality in Cuba, and I had the responsibility of every month to tell the assembly what was the state of healthcare in that area. First, it was part of the monthly monies that the community or the area received in each of the communities. But there are two processes: is to reduce the accounts of the manager of that area, the popular manager, that is the delegate that is voted by the municipal assembly. So you have a doctor and a nurse of the family, and once a year they have to say what they have been doing. And then we form a discussion, and the demands of the population are met. So are the two ways that we do in a practical way. We ask people to say what they did. It's a control process that is done by the systems, but it's also for us to organize our time. We have an important role in doing that at different levels. At reference and counter reference, it is a challenge, but I believe that we are on the right path. It's not going to be a short one, this path, but we are on the right way. We are going on the right direction. We are associating that to digital transformation, and we are doing that. We are designing this process in Cuba. We don't have it available due to the lack of technology, but we have the intention of doing that. From the surgery of the doctor and the nurse, you refer the patient to the hospital, and then he comes back. And in a cell phone, you have the chance to follow up that patient. You know what's happening to them every moment of the consultation and the treatment. We have also emergency. We have intensive care also in the polyclinics. We have a first health care, and then you have a kind of triage, and then you can refer that patient to the right experts in terms of urgency and emergencies. Thank you.
Well, regarding the driving institution for the comprehensive networks, we are in a diagnostics phase about the situation of each country in the region in order to identify needs and design a work agenda for the next months, in which the idea is to work using commissions and the dimensions, as Gustavo said. And you are all invited to work with us in this commission. We'll have work groups, and you can talk to Gustavo and enlist. Regarding social participation, in Uruguay we have some workplaces in which, for example, we have the board for health with voice and vote. We have health departments in of the state and local health departments that are in which the users are the ones who move the agenda with the support of the Ministry of Health and the different services on the local level. At ACE, which is the largest public provider, we also have the representatives of the users, and where they are heard and they have vote. And we also we work with the users on the territorial level. Currently, we have an ongoing work on group-alities that the users are the ones who boost it, and we support it as technical group. Regarding intra-level integration, we have the electronic health history, and especially when to be used when, for example, the patient leaves the hospital and goes to back home. Then we have the counter reference also to follow up on children and the elderly. It works very well. Regarding the community health agents, this is very interesting. We have much training at the University of the Republic. We also have training courses for community agents, but they are not part of the health team. They are considered important, and their contribution is essential in follow-ups and different steps of the care and health. Still, they are not part or not considered part of the health professionals team. But this is an advancement that we have to move, but because they have to earn this role in the different countries. Thank you very much for everyone, especially for your awareness with time. We are only 4 minutes late, and that makes me very proud. I would like to thank everyone for your attention, and Pajo for giving me the opportunity to coordinate this discussion. Thank you very much. See you soon. Ladies and gentlemen, at present moment, we'll begin our parallel sessions. We will be divided in 3 rooms. Here in the auditorium, we'll have the panel 1 called PHS, and then we'll have the other in room 910. We'll have multi-professional teams in PHC, and in room 417, we'll have evaluation and strengthening of PHC, focusing on waiting lines and management. We remind you that the rooms have low capacity, so if they are full, please go to another panel. We also inform you that there is simultaneous translation in all rooms, and for that you will need to exchange your translation device when registering. Those who will remain here at the auditorium do not need to do so. Thank you very much.
Senhoras e senhores, neste auditório iniciaremos em breve o painel chamado APS e o enfrentamento às emergências.
We're going to begin our panel about PHS and response to health emergency. On room 910, we'll have the topic multidisciplinary teams in PHC, and then room 417, we'll have the strengthening of the healthcare system, focusing on waiting lines.
Solicitamos, por gentileza,
Please, could the panelists from the second panel come here to the front of the room or to the stage, please? please, panelists of PHS, how to face the problems of health and strengthen them of all the health systems. Could you please come here to the front of the stage?
Neste momento, para o painel APS e o enfrentamento.
Now we are going to have the panel PHC and facing health emergencies. We shall invite then the moderator, President of the National Council of Secretaries of Health, Mr. Ijan Samidi. The Subdirector of PAHO, Mrs. Honda Silly Thomas. The Deputy Minister from Guatemala, Mr. José Donato Camei Rus. The Director of Services of PHC from the Dominican Republic, Mr. Andy Hilaire. Superintendent of Health Surveillance in the Secretariat of Rio de Janeiro, Mrs. Gislane Mateus. And the national responsible for the team of comprehensive health care from Peru, Mr. Henry Hernandez Cavalero. COVID pandemic, and what were the lessons we learned and how we faced it, also associated to the climate change issues that have been impacting our planet. When we think about Brazil, but we have to look at all the emergencies that might arrive in those territories, like it happened in the pandemic. We had arboviruses that appeared, and how to bring immunization to all the population as health promotion, and also the climate change. In my region, the Amazon, there are times of the year where we cannot navigate. In the Amazon, mostly we use the rivers, but sometimes there are droughts, and I can't bring health to the population. And so what is our role as primary health care when we have to face such challenges? As a moderator, I would like to ask you some provocative questions. I would like to give the floor to Rhonda, but I would like to leave a question in the air so that we can think about how does our PHC articulate in terms of surveillance and response to emergencies. what has already worked in your country, what has not worked, and what are the hurdles, the obstacles for something to work. So I'll give the floor to Ms. Siley Thomas.
Distinguished ministers and vice ministers, colleagues from the World Bank and the IDB, esteemed delegates from Brazil and valued partners, and other panel members, good morning. Thanks for the opportunity to speak on a topic that is essential to our shared mission, strengthening primary health care so that it can more effectively protect our communities before, during, and after health emergencies, which in our context would be hurricanes, floods, disease outbreaks, volcanic eruptions even. Today, evidence clearly demonstrates that resilience in primary health care is not a luxury. It is a necessity. A recent landmark World Bank, Pan American Health Organization, Lancet Regional Health Commission report highlights that failing to build strong, resilient primary health care in the Americas could lead to hundreds of thousands of preventable deaths and severe economic losses in future crises. Robust, community-rooted primary health care must be the cornerstone of health security across Latin America and the Caribbean. Primary health care is essential in emergencies, serving as the front line for detection and response to disease outbreaks and other health-related threats. Community-level providers are often the first to identify unusual patterns of illness, making them critical to early detection, reporting, and response. Integrating essential public health functions such as surveillance, risk communication, vaccination, and health education within primary health care ensures that emerging threats are identified early and addressed promptly. To achieve this, epidemiological intelligence and interoperable data systems must be strengthened to equip primary health care teams with the tools that they need to detect, verify, and interpret health threats at the community level. Resilient health infrastructure is another pillar of emergency preparedness. PAHO's Smart and Green Hospitals initiative supports the design and upgrading of health facilities so that it can remain functional in crises, whether hurricanes, floods, or outbreaks, while reducing energy consumption and environmental impact. These facilities, in the Caribbean in particular, are structurally sound, resource efficient, and adaptable, and they strengthen the initiative with renewable energy and water resilience. The initiative in primary health care are a move further than physical structures. It ensures continuity of essential services, especially when communities need them the most. Of course, resilient facilities and systems are only effective when they are supported by a skilled, well-trained primary health care workforce. PAHO has advanced compensatory frameworks and training programs that equipped healthcare workers with the skills needed to manage emergencies and disasters. These frameworks emphasize clinical preparedness, decision-making, teamwork, and community engagement. In addition to digital tools, PAHO's ability to respond effectively during emergencies is strengthened through interoperable health information systems, telemedicine platforms, mobile reporting tools, and digital surveillance, which enhance our ability to monitor health trends, maintain continuity of care, and communicate risk during disasters and other health emergencies. PAHO's work to expand digital infrastructure harnesses the power of data for better decision-making and more equitable access to services in even hard-to-reach communities when disasters strike. Finally, primary health care must be central to governance and management of health emergencies. Primary healthcare leadership needs to be integrated into planning, budgeting, and crisis response mechanism, not as an afterthought, but as a core decision-making partner. Community perspectives must also be heard and trusted so that policies reflect local realities and resources reach those who need them most, especially in most marginalized communities. Resilience, equity, and preparedness go hand in hand. Investing in strong primary health care anchored in resilient infrastructure such as the smart and green hospital facilities that has been supported by PAHO, also supported by digital innovations, led by skilled local teams, not only protect lives during health emergencies, but advances universal health, social stability, and economic prosperity for all. Thank you.
Bom, já vou passar aqui para comentar.
I'll give the floor to Mr. José Ronato from Guatemala for his comments. Thank you for inviting me and for the fact that I can share some important aspects that our country was able to develop based on the characteristics that we have as a country. I would like to share the mission and the advancements of Guatemala in strengthening PHC and also to have a more comprehensive health care with an intersectorial participation. And also we have to affirm or reaffirm the commitment with early on exams and early detection of diseases for the prevention and the response in emergencies in public health. I would like to talk about some aspects of epidemiology and surveillance. We have an comprehensive proposal according to the characteristics of Guatemala. And we have some challenges to recognize the diversity of our country. I have to emphasize that we have a way of understanding the disasters, the emergencies, a way of diagnosing them, a specific way of understanding this kind of situation in different communities because everybody is different. We have had this kind of situations of disasters that risk communities and public health. So we have the coordination at the community level with organizations of peoples, different peoples, and those who know the country, not only in their approach, but in their diagnosis and the understanding they have of the different communities and their problems. At the same time, we have a mechanism, an internal mechanism within the Ministry of Health. We have a department of risk assessment that includes the Ministry of Health and also a state communication where we have a national council for resolving disasters. And there is a participation of the different actors of the community. So the social cultural surveillance is in different levels, individual and community level, to evaluate risks according to the local community. We have an articulation of the epidemiological situation in terms of the population and the environment. The focus we have seems to be very clinical, but the PHC should meet the demands to understand the cultural differences at the different community levels. So we must have not only a network of services in the medical level, but also a community network where we have the actors of the ancestor models of the original peoples of the country, and they face disasters in a different way. We have community leaders that should be heard, and they have an important role in the health of the communities. And we have also to form different teams that will notify in real time the problems and the capacity we have for decision making. As to risk management, we have a surveillance and healthcare model that meets the demands with surveillance mechanisms, control, and quick response vis-à-vis disasters. the attributes like the quality of continuous follow-up and democratic governance will ensure a good response facing crisis, and it guarantees the cultural maintenance. As to the networks, the PHCs, we have community leaders, and we have notification and risk management that strengthens the networks of primary health care. In many places, we were successful in having actors from different sectors of the society. We have indigenous people and community leaders, and we have an office where we create an emergency plan. We make a diagnosis of the risks in terms of flood or other environmental disasters that might affect that specific community. So we make plans to be able to meet the demands of an individual emergency or a major damage or disaster, so that we can have collective decisions when it would affect the whole community. So we analyze each situation together, and we have also mechanisms that will allow us to intervene in the community, and the community participates promoting decentralized networks and emergency plans. And for action plans, we have international help. I'm not going to talk about that because you know it. But if we are using that for emergency, it's a plan that we have. We use this method. As to the strengthening, we have processes to do that. For sustainability, for the response to emergencies to be sustainable, we must have a democratic management so that we can have PHC, healthcare, and also healthcare to those who are most vulnerable. And we have a good logistic to have resources for this healthcare in a continuous and sustainable way. And we have a performance analysis also with the quality indicators for our responses. We have also some national advances. We have strengthened our framework of quick responses, and then we have many resources that strengthens the mechanisms of surveillance so that we can deal with outbreaks. And to conclude, Guatemala has a commitment to implement a comprehensive surveillance and PHC system that integrates culture and also the society. And we have institutional processes to guarantee that our services are always present in emergency situations. Risk management in networks will also include the community participation when you have to face threats. Finally, we have a more robust health system that is inclusive and is prepared to face any health emergency.
Okay, now I would like to give the floor to Mr. Andy Set from the Dominican Republic. Andy Saint-Hilaire.
Good morning, everybody. Good morning. All right, I'm coming from Dominica, a tiny island in the Caribbean. We are located in the middle of the Caribbean chain, and the island is very small. It's 29 miles in length, 29 kilometers in width, and it's 290 square miles in area. The language is English and French Creole, and the people mostly Afro-Caribbean and of Carib Indians. The currency is Eastern Caribbean dollars, and population is estimated to be about 72,000 people. Next slide, please. So Dominica calls itself the nature island of the Caribbean. Dominica sits on 9 active volcanic areas. And because of the location of Dominica, we are in the center of the archipelago. We are exposed to adverse weather events. Since 1883 to 2017, Dominica has experienced over 22 adverse weather events, with the last one being Hurricane Maria in 2017 that destroyed the island totally, 194% economic destruction. So with that in mind, in addition to hurricane, we also battle with pandemics, and we had the COVID pandemic to deal with. So Dominica developed the Dominica National Emergency Planning Organization, called the NEPO, and NEPO served as the central body for coordinating, planning, and implementing disaster response. NEPO has 16 core areas to deal with, and one of them is health. And the connection with the National Emergency Response Organization and the Ministry of Health is that the Director of Primary Health Care sits on the NEPO subcommittee. And the NEPO subcommittee is chaired by the Prime Minister of the Commonwealth of Dominica. So that gives a level of priority to disaster management and emergency care. So the Ministry of Health had formed 2 emergency documents: the National Disaster Management Multi-Hazards Plan for Health, and the Health Emergency Operations Center, the Concepts of Operation. And from that, we define what emergency is and what levels of emergency. So level 1 emergency happens at the primary health care level, and where responders, the district health teams, the fire and ambulance services, the religious organizations in community, they are activated, and then they respond to the type 3 health centers. Now in Dominica, in primary health care, there are 2 types of health centers. There is the type 1 and the type 3s. I will talk to that in the next slide. So if there is a level 1 emergency, it happens community level, the community health center activated, and based on what is going on, if it warrants a level 2, it activates the hospital system, and then depending on what is happening, the hospital system will activate the National Health EOC, and then that might end up to level 3, where it becomes a national disaster, and it activates the National Emergency Organization Committee, which is a function of NEPO. And then, based on what's going on, we call on the international level for help. So I said that the primary health care, we are 7 districts with 49 health centers. 42 health centers are classified as type 1, and 7 MH gap training program in terms of mental health to gap the difference between the primary health care and the secondary and tertiary health care. And we continue simulation on emergencies in public health. Ladies and gentlemen, I thank you.
Now I will pass the floor to Gislaine Mateus from the Municipal Secretary of Health from the city of Rio de Janeiro. Good morning, everyone. I would like to thank everyone for the opportunity to share what Rio de Janeiro has been doing and representing also what Brazil has been doing regarding primary care in order to face health emergencies. Well, the first issue I would like to talk about is because we're talking about Rio de Janeiro, and we need to know its risks because that is important for us to know how to prepare to respond. So we're talking about a city that has over 6 million people. It's the second largest city in the country. It receives over 5.1 million tourists annually. Actually, the carnival this year will already surpass that number. And most part of our population lives in poor communities called favelas with low social development and face different risks within their own territories. We also have a humid tropical climate, so it's a warm city with much rainfall. And so the health and climate risks in Rio are high. We must get prepared, especially when we talk about outbreaks and epidemics, and also climate emergencies. And that is why I'm wearing the Curupira, the COP30 mascot, which helps us understand the importance of the dynamics and the whole health system and primary care, which is the closest to the people. So by knowing our risks, we must also understand our powers. How is this health system organized? How can we make it closer to people? So in Rio we have over 240 primary healthcare units. You will be able to visit one in order to know how we organize here in Rio, which is not different from the rest of the country. However, a large part of this 80% of this territory is covered by a family nurse or physician, an oral health team, and also a community health agent, because it is important for us to emphasize their important role, because it's a person that lives in the territory that is connected and then makes the connection between the territory and the community and the health care unit. And we also have surveillance system in Rio. It's based on the community, but also digital and epidemiological. And it is important that we emphasize that along the years, we are aware that public health emergencies will become more prevalent, so we must be prepared to respond. And the first level of response is the primary health, which is closest to the people themselves. This is just a trajectory from 2021 on, but since 2020 until now, we've lived many emergencies here in Rio. COVID, Mpox, the heat waves of November 2023 that were very extreme weather events that were unprecedented in their intensity. We also had floods in 2024, the dengue epidemic, in which we saw the highest number of cases in history, however, with a lower rate of mortality because of our primary care and surveillance systems. Also fires and heat waves. Just showing you a few numbers about if we did not have if we did not have this surveillance, we would not have this data. And this is our reality now. So now about how we are working to strengthen our system, which is my goal here with my speech. First of all, we have a very capillarized system, and it's connected to the surveillance, and it participates in the whole management of emergencies, since it's analysis, detection, communication, response, and recovery of the territory after an emergency. COVID taught us the need to strengthen and learn. There was the most severe pandemic. It costed in every aspect to us. However, we learned in Rio de Janeiro with the pandemic to expand the resilience of our system, and primary care had a crucial role in this because that is where we organized vaccination logistics en masse. PHC was one of the testing poles, also our contingency plans in order to care for our priorities, because if we were going through a pandemic, we still had our other priorities to care for, and that took a lot of preparation and resilience of our system. But I am focusing on PHC integrated to surveillance, monitoring of contacts and information sets. And so this was important for the reopening of our city and taught us how to build a PHC adapted to emergencies without lacking attention to our other priorities and emergencies. So what we saw in 2024, we saw floods in Rio, and this also put another item in our system, which was the resilience of our own physical structures and systems and how to organize. Today, we have over 80% of our endemic agents and community agents that are trained with our civil services for the contingency of the natural disasters, and that shows how important each agent is important. And here we have a few actions that were carried out, but I want to emphasize the actions that take place in the territory, even when it's a territory that is not so accessible. But in order to ensure monitoring and prevention, and we have several actions. Also, the dengue epidemic that we lived in the beginning of 2024 brought awareness about the intelligence related to health. I think many of you visited our epidemiological observatory yesterday, and that shows how they can predict and help us make a more timely surveillance, and that helps us prepare the health system as a whole. And as we did with COVID, we were able to ensure that PHC units were accessed for dengue, that prepared poles with the possibility to do the blood tests in the PHC unit itself. We had a record number of dengue cases. However, 80% of them were treated in the PHC units, showing that it was able to strengthen, expand its capacity without, and also prioritize its other actions and priorities. They also showed us the capacity of mobilization and territorial coverage, because we have the agents that deal with endemics that are integrated in our PHC. And this made sure that we had a low mortality rate, the lowest mortality rate regarding dengue epidemics in Rio de Janeiro. And you could see that in 2018, we had 160 people dying of dengue in the city. It was important to have a system that is organized and expanded, integrated to the surveillance system. So this coordinated action as a network makes a difference. And recently, just to conclude, we had extreme heat waves that are unprecedented in Rio de Janeiro. We saw areas with higher risk for warm heat waves in urban areas because of insufficient vegetation coverage, and that made us reinvent ourselves again. So Rio was the first city in the country to have a protocol for heat waves. We're integrating not only health but also the environment and the civil defense, and that's why we have all the data on Rio, both from health and climate, are classified by levels of heat in order to plan our response. We have different heat levels, and according to each level, you have new response actions that are activated. And regarding PHC, we have to reinforce that it is the closest to people. They know who has high blood pressure, who is a child, who is the elderly, who are pregnant women, and who has diabetes, and is able to ensure the communication about the risks, but also the response. And this ability with this infrastructure to have a hydration room in the PHC has also been very successful and important for PHC to ensure this process. So if you're today that you're here in Rio, I recommend you downloading our Color Rio app, so where you can see the level of heat, the operational stage for rains, and safety recommendations. But we know that not everyone will download the app, so we ensure that this reaches the population when we have community agents and PHCs all around the city. So we have the warnings, then we have the attention and the recovery, and all of this is integrated to an intersectorial network. I think I touched on the most important points of our recent emergencies here in our city, in emphasizing that PHC is a strategic axis in facing these emergencies. It expands the resilience and the adaptation of the health system in this context of emergencies, not in an isolated way, but in an integrated way, with the surveillance and civil defense and other intersectorial areas. And this strengthening of PHC is paramount to expand our capacity and ensure protection to health, reducing inequalities, and ensuring care for everyone who needs it, which has been a growing challenge. And it's been advancing according to each emergency and to each challenge we've been facing. Each emergency contributes a new building block to the city's resilience. Thank you very much.
Nacional.
Now we have Mr. Cavaleiro from Peru. Thank you for inviting me to come to your country to talk a bit about the work we have been doing in primary health care as to the response when we face health crisis. My country is a territory that's very different regions. We have the El Nino and La Nina phenomenon in the north area, and we have also lots of rain. And in the hills near our neighbor Bolivia, we have lots of cold. Sometimes we have people that die from pneumonia, especially children, and also the elderly. But we also have volcanoes that can erupt and then generate an emergency. But what is common to the whole region is earthquakes and sometimes floods because of the earthquakes. So we have a long experience with disasters, and in the political level we have planned for emergencies and disasters and health emergencies. COVID taught us a lot, and we have been developing national plans. We have a national plan of risk management that also includes disasters up to 2050, and mainly we are linked to PHC. What is very important that we work is a permanent surveillance for possible health emergencies, mainly the coverage of vaccination that is so important when they affect, when you have an outbreak. If you have a low coverage of vaccination, most of the population will be at risk. I'm talking about the vulnerable population, lower than 5 years old, pregnant women, people that are incapacitated, and also the elderly that are growing in number. So the experience we had during COVID, unfortunately, at that time, the first level of attention didn't have the right response. And we thought that the hospitals could give the right response with immediate response teams. However, we know that this didn't happen. The first level had to work later on, but we had to be ready for that, but we were not. So because of that, now the teams of first level is integrated to the equality model so that they can act in a more fit way. On the other hand, we also know that this vulnerable population could have been affected, like in COVID, the diabetic people and those who have high blood pressure, and also the elderly. They were the ones who died because it was not controlled. PHC with multidisciplinary teams now allow us to localize, to know who is where, people who are most vulnerable in our territory and where they are due to their age, due to the region they live in, and the level of control. So the work with primary care is essential. Another important aspect is the intersectory work that we do and we carried out via our plans. Then we can have a response per level. The first level of emergency is at the local level, at the province level. When this has been overcome, we enter the level, the national level, and sometimes we have to declare an emergency, and then the managerial mechanisms are activated so that we can have an immediate answer facing this situation. What have we learned? We have learned a lot, and we are learning more and more, but we have to approach the social determinants so that we can have a better response to the population, because the population is what matters. And the second is that we have to have information systems. Interoperability is important, so we must have an active digitalized system that can strengthen the infrastructure, the levels of safety at the hospitals, so that the first level of attention can be evaluated permanently. And to finalize, I would like to say that it's important to work with the community. Each local government has learned during COVID to identify the safe areas, and you can have contingency spaces where the population can go, and we can take medication to this population in those safe zones, and their treatment can be continued and not interrupted. For instance, people with HIV/AIDS, tuberculosis, and others, because they are in a safe space if we are in a contingency space. That's all I have to say. Thank you very much. So we have very interesting themes. Rhonda talked about resilience and primary health care, how challenging it is. And from the cultural point of view, we have to recognize the importance primary care has in the network. So the role of primary healthcare and how to organize a network and the challenge of integration per se. How can we recognize the importance of PHC as the coordinator, as the entrance door? But we need technology, we need good professionals, and there are other variables also, the social determinants, even the issue of recognizing the community at its own territory. Dominica, with a little more than 70,000 as population, and I'm talking about other regions in Brazil. We have municipalities with 12 million people. And in Minas, you have municipalities with 830 people. Each presents a challenge, a territorial challenge. How can we integrate all the variables, climate change and others? How can we guarantee to bring PHC to those regions that are a system that is resilient and sustainable in the case of an emergency, in the case of a pandemic or an epidemic? We can be prepared to face that. What are the lessons we have learned from the past? Gislani talked about Rio, and I think that what the lessons she has been learned as time goes by is preparing the city to the next steps. So the example is the pandemic of COVID that affected everybody. What are the lessons we learned? Can we face another pandemic, or are we going to make the same mistakes that we made in 2020? In the beginning, that we are dealing with the unknown, the COVID. Do we have input with sustainability? Do we have an organized network? Do we have experts who are prepared to deal with such a challenge? If we have yet another pandemic of COVID, we know a bit about it now, but we can go forward if we don't have the primary health care that should be strengthened, because it is the entrance way, the entrance door to any process. Do you like to add anything, you panelists, or should we open to the floor, to the audience? I'm sorry. So we have 2 questions already from the audience. 3. Good morning. I represent Rio Grande do Sul. We had a year and a half. We had a disaster in my state. And not only in my state, but we had 97% of our municipalities were affected by floods with a rain that was non-stop, that happened in May 2024. All Brazilians know about that and know about the major disaster. More than 800,000 people were without shelter. We had 190 deaths, and people were rescued from their residences, from their households, and we had to have a good organization, and then we perceived the need to be integrated with the other forces in our territory, in and outside our state. We have been working with developing an integrated protocol for responses to climate emergencies, that goes beyond our contingency plan, that approaches more the healthcare system. But we have to be aligned with the civil defense, with the security groups, the social workers, and we must have an integrated plan that could guide the actions if something like that happened again. In the last 5 years, We had at least 5 major floods in my state. It started near the coastline, then it went all over the state. So those climate events, the severe ones, are happening more frequently, and we have to be prepared for that. In Paraná and Santa Catarina, also states from the south of Brazil, we had disasters also with a big devastation. So how would you, or how do you do this integrated sort of work, going beyond the healthcare? In our experience, sometimes we couldn't even go from one city to another. We had to use the Air Force, the Brazilian Air Force, so we couldn't handle it alone. We needed the national force. We had a national force from our unified health system, the SUS. They were available to come to our state to help us. And they were a main force, a main source of help. So, and we have to think about the expansion of those national forces so that we can have a quicker response. So these discussions are being carried out in our state to see how we can help one another. The state of Rio Grande do Sul is in a border area with Argentina, Paraguay, and Uruguay. So these countries also supported us in the health care, not for primary health care. We had more than 200 teams that had their basic units affected by this flood. And also the shelters that we had. As a primary health care, we must also be very attentive, because sometimes we put the whole population in just one territory. If I think about a territory, we have shelters there. And this is very important. So I think I had to expose the situation that we lived in Rio Grande do Sul. It was very difficult, although we had previous floods, but not a major one like that in 2024. And what are the challenges for us to organize ourselves at the regional level and national level, and in terms of management also, so that we are organized and are not surprised by future disasters. We can be organized at all 3 levels: national, state, and municipal level. And also we must have resources, financial resources for emergencies, so that can be used to reconstruct places, and also for the support of teams. The teams of PHC, they were there at the local areas. The locals that were isolated, that had to move to shelters, we must understand that those teams are also affected. The community agents, because they live in the area and they need our support too. So those are major issues that we have to try to solve, so that we can give support to the right people that are affected in those disasters. In the last 5 years, we started being more prepared for heat waves, and also we have severe winters in the south of Brazil too. Thank you for your attention. I am Fernando Sanches from the Federal University of Rio de Janeiro, and I am in the area of tuberculosis. As it was mentioned, TB lately is related to the issue of PHC, associated to all the transformations climate change, lack of resources, bad distribution of wealth, social differences, all those issues should be linked. I'm going to make a comment and and I would like to call you as a community. We have been seeing, not only in Brazil, we work with the National Council of Nurses and the council that controls TB and some units of health with the theme tuberculosis. And our actions need political will. Our plan to control TB in Brazil describes some scenarios that are important. We need the participation of the nurse team in the control of TB and also within primary health care. We have specific programs that are done in the partnership with the Ministry of Health. We have partners within the national plan for TB. And my question is, if in any of your countries, do you have a specific network of nurses to eliminate or to try to contain a public health problem such as TB? Or what are the actions that you have? Are they within a policy? Are they specified in a national policy? I would like to hear from you. How are the policies made for some professions, such as nurses, in a multi-professional team? And how can the political will penetrate the different plans, not only by the Ministry of Health, but at the local and regional level also? Good morning. I congratulate the panel for your presentations. I am Lely Guzman from Parro. I work in Brazil. And my question is for you as representatives of your countries, Dr. Honda, that represents Parro too. How do you see that this alliance for primary health care can offer a difference between work for emergencies, not only epidemic, mental health or emergencies, but how do you see the alliance that can organize better to differentiate these processes, to have a quick response for emergency per se, and a difference between the routine issues? We are talking about PHC, we are talking about community agents, and the people who are at the front line at primary health care at the municipalities. They see that on a daily basis, and they have to communicate with the community. How do you see the alliance as a strengthening for these problems? Just one more question and we'll go back to the panelists. Good morning. I am Luanda Lima from the Brazilian Association of Collective Health. Congratulations on the excellent panel. My question is similar to my colleague from Rio Grande do Sul. When we talk about climate emergencies, major environmental disasters, we don't know how to pin where it happens, because climate doesn't respect borders. So how in your contingency plans, in the process of preparation, how the Alliance has been seeing this dialogue between countries. The problem can occur in a faraway place in Guatemala, for instance, but it will affect other countries in the South Cone. How can it will affect Brazil? Or when it happens in the state of Rio Grande do Sul, there is an impact in the network in the state of Rio. So how does the alliance think about that in the contingency plans? And also the talk of my colleague from Guatemala was very important because the dialogue with the original peoples, the traditional peoples, because they are in Rio, they are in São Paulo, they are also in smaller countries all over the Americas. How do the knowledge of these peoples demand a different point of view? How do you think about them in this alliance? Well, I will start by answering some questions. How to think and prepare better, and how to organize primary health care between emergency and routine and TB in this context. It's in the routine, but when we look at the maps, we see that those who have tuberculosis also have a social status. When we look at the impact of health also in the climate change problems, you have also the same social class being affected by those epidemics. So what I think is important is the preparation. It's not at the crisis that we have to prepare the team. It's not at the crisis that we have to know what we should do. We have to prepare for that. The knowledge has to come beforehand. We have to think about different scenarios. We have to understand that the parameters at what we call levels or stages or warnings, we have to understand at each scenario, we have to know how to prepare. For instance, rains, we have support points, all simulate also at what levels and how can I respond and what I can maintain in terms of service. We had levels during COVID that were very intense and many services were harmed, but in an organized fashion, organized with the network. Not everything was maintained, but when a new level came, we wanted to recover what we had lost. But this must be done organized in networks, and I think it can be articulated in country with our neighbors. We have here points of support for the rain, which is different from the shelters, and we had to organize. We have a management of shelters that is different from support points. In a support point, you have hours to stay, and the water will come down, and you can go back to your home. But we have to treat the water, we have to teach people how to clean the spaces, and you must have teams to look at the routines. We cannot wait for 15 days for recovery. We must have a contingency plan, but we have to create scenarios in social assistance, civil defense, the environment, and the climate. So I think there is still a need to prepare better, because I say that we learned with the emergency because we were not prepared for everything. But we have one of the managers of floods. Today, the people who live in the community themselves, they inform for the unit of primary care where the water is. Sometimes our sensors don't yet know about that. So we are in a network together with the community leaders and the community themselves. Our resources are limited. The social issue is important. There is the mental health of the workers that has a major impact for how to deal with emergencies, but I think it's possible to prepare better. And a good preparation, a qualification of professionals to think about the infrastructure around everything will lead us to a better response in a more effective way with less collateral impact to social and primary health care.
There are three important elements that were mentioned, and also in the questions, and according to our experience, I think we can share a few, and I apologize if my answer is not complete. In Guatemala, when the model was presented for the PHC-based model, the community diagnostics was peoples and the wise men from the communities. What are their roles within the community? Some of our ancestral leaders, others are therapists and therapeutics, others are observers of the weather, and they can predict if there's going to be rainfall or drought. They also try to prevent, and they alert and warn and prepare the community for what they foresee for in the future. And that is also taken into account in our management process for the community level, and also the respect we must give these actors and their leading role and importance that they have within the community, because they are respected by the community, they are leaders. And if we want to intervene and create policies or strategies or plans on the community level, we should also do this incidence, because I believe that someone was mentioning that and talking about how to do this and incidents. So when we build these emergency committees on the community level, they are actors and players that should be involved. The therapist that can heal or treat somebody, and also the man who observes the weather or makes diagnosis. They are important actors within the community. But also, when we formulated the PHC-based model, we had 4 perspectives, and I will emphasize a few, which is the right to health, the pertinence, the gender approach, and an important axis was the respect for nature, for Mother Nature, because oftentimes that is not taken into account. We have many nice processes with more medicine, drugs, and technology, but we do not evaluate the harm we impose to these communities when we are driving these processes. And so as health actors, as technology generators, we must have this in mind, that our actions should not harm Mother Nature. And that is part of prevention as well, because in Guatemala, for example, is one of the largest, countries with the largest risks for earthquakes and droughts and floods because of the characteristics of the country. We have learned to coexist with that, but we must know what to do. And my grandfather once told us that if you put this specific company in this place, I hope I'm not too mysticism, but he said, if you allow that company to be installed in that place, it will change the climate of that place. And it really happened when they built that company, that manufacturing plant. The weather started to change. We had extreme heat waves. Some vegetation did not grow anymore in that place. We had a different rainfall rate. And because historically, there are 3 mountains that operate, that control the microclimate in that place. And the installation of that company, of that manufacturing plant, altered the normal climate, and it impacted the people there. And in this case, what our influence in the when of course the executive branch as well has to be responsible. So I hope to have been able to answer your questions and comments. Thank you very much.
For the questions and the comments, I wanted to respond to the areas related to how you get an integrated response in countries and how the Alliance for Primary Healthcare really assists with that. And what came to my mind and was very critical and an important part of the Alliance for Primary Healthcare is the Mesa Consultiva, which is basically a table where we bring together different ministries, different sectors in countries where they sit when they're looking and they discuss when they're looking to strengthen primary health care. So becoming part of the Alliance for Primary Health Care, which is, as we know, is the joint action between PAHO, the IDB, and the World Bank, as part of that alliance, the MISA Consultiva brings the different sectors together so that when primary health care is being discussed to be strengthened, it's not just health that is involved. It's the Ministry of Finance, it's the Ministry of Infrastructure, telecommunications, all the sectors that would be necessary for, particularly and especially if there's a public health response is needed. Also, additionally, within the Alliance for Primary Health Care, it's not just at a country level. The Alliance is also working at a regional and sub-regional levels to studies, for reports, to generate reports, to give responses that can be adapted to particular countries of a particular sub-region. So it's not just a country-specific, but they also work at a regional and sub-regional level. And I also want to say, as PAHO, although we are in public health and we, for example, as the assistant director, I oversee 8 departments. They don't work in silos as well. We work interprogrammatically. So if we're going into a country, we don't just look, for example, at the health workforce. We look at the health systems. We look at information systems. We look at things like telemedicine, maternal and child health in an integrated manner, not just in silos. And also to go back to the point about how, I think there was a question on how, for example, if there's a disaster or a public health emergency in one country and it affects another country. At PAHO, we would coordinate at headquarters, but we have 27 country offices. And in country offices, our director, Dr. Barbosa, it's always that we have to make sure that we maintain the technical assistance and strengthen country offices. So although there may be a coordination from the Washington, D.C. headquarters, that coordination involves country offices, and we connect countries through our country offices and our PWRs and advisors and consultants that we may have in countries, so that there's the support on the ground if there's a disaster in one country that affects another one. Thank
you. And as well, in terms of primary health care, we have to think of the role of primary health care, preventative and people-centered. And when we look at this in terms of emergencies, we have to always remember that we are connected. We're supposed to be connected with people on the ground, the community level, the church-based and the other youth groups and so on, and have a vision. And in order to do that, we must have focus. We must be able to see and forecast things, especially related to climate change and trending diseases, and so on. And based on that, we're supposed to be planning. And when we plan, constant review of our planning and the systems, I think is going to push us forward in terms of delivering in primary health care. Thank you.
Sí, a manera...
As a commentary, when you talk about risk management or the risk assessment, there are a few ways that we can address the risk management, because it's usually a probability, it's not a certainty. But first I have to prevent it from happening, and there are situations of emergency that can be prevented and avoided when risk management and risk assessments are well worked. And sometimes we can eliminate the risk totally. But however, when I am not able to do that, I can mitigate the impacts that these risks can create. Uh, when we work on plans, we know that the daily management makes us forget the execution or the measuring if these plans were well elaborated. At the beginning of the year, we usually have to analyze if the climate is changing, if we'll have more rains or less rains, and we have to plan for that because things may happen or may not happen, and that is why the manager and the management is very important. Someone with and the experience, because when you mobilize resources at a contingency moment, is not so simple because it will affect others. You can plan for a specific amount, but with time, the contingency may demand that you make more investment, and that will therefore affect other services and other cares services. And we live that annually. We plan for something, but if the risk happens, we have to act. And it is important and I think that authorities have this in mind. However, sometimes it's hard to recognize possibilities in the moment. And that is why the technical staff is present to make people aware that things may happen, that planning has to be carried out. There is no perfect planning, but based on that planning, I am able to respond to these three aspects I mentioned. I can prevent, eliminate, or mitigate. And based on that, the response depends on that. And the local level, it is important, and local governments have learned this as well. Each local government must know its own reality, and that based on its reality, they must plan and have its contingency plans and actions. I believe that the Alliance can contribute based on the commonalities and the common risks that we face. There is the possibility for recovery investment for emergencies that cross borders, and that may be necessary in times of emergency. I know we have different strengths in comparison to other countries, but maybe we can collaborate to encompass the whole region in order for us to support each other in face of situations that sometimes exceed the country's capability to respond.
Ninguém.
Quisiera agregar algo.
I would like to talk about a very concrete action that we have carried out when we have workshops or capacity building seminars. We don't allow people to use things like bottles, water bottles like those we are using here, made of plastic. So we just, sometimes we have 20, 30 people, or sometimes even 5,000 people, and then it would generate lots of garbage. And we don't want to do that. So those are concrete actions that we can use, or not use paper, for instance, to not to waste. And also the food, like a hotel food or restaurant food, must be a healthy kind of food, so that we can activate our economy and also we're not going to contribute at a local level. At least we can mitigate a bit of waste. That's just an idea. Well, thank you very much, you all. I would like to thank you all for your comments, for your participation in this panel. I would like to thank PAHO, the Ministry of Health, the World Bank, and the IDB, because we have learned a lot and we have food for thought also. And let's hope we can implement what we have learned so that we can work with prevention due to the impact of climate change, pandemics, epidemics. And also we have to have in mind the workers, the health workers, the health professionals, because they are responsible for caring for our health, and they are also affected by all the disasters and all the emergencies. I would like to thank you all for your comments and your participation, and we are closing this panel. Thank you. Ladies and gentlemen, now we are going to have lunch, and we shall be back at 1:30. Thank you.
dois, testando.
Señoras y señores, en algunos
Ladies and gentlemen, in a few minutes we will begin our afternoon sessions. Please take your seats at the auditorium or at the parallel rooms. Thank you very much.
Señoras y señores, antes de comenzar,
Ladies and gentlemen, before beginning, I would like to convey a few messages. Today at 3 o'clock p.m., we will have a visit to the Super Centro Carioca de Saúde with a health unit. You are all invited to participate. Tomorrow, at the end of the event, we will have a visit to a basic health unit, and you are also all invited. The meeting point will be at the same spot as yesterday. We also like to ask you to please, at the end of today's panels, you return your translation devices in the registering point. Now we will begin our afternoon panel with the topic, the workforce, employment, work conditions, and migration. I would like to invite onto the stage the mediator of our panel, Mr. Joseph Figueiras, Emerit Director of the European Observatory of Systems and Health Policies. Then the chief nurse of the Ministry of Health of Santa Lucia, Ms. Juliette Frederick Cassius. The Secretary of State of Health and Sanity of Spain, Mr. Javier Bernaldez. To the Chief of Staff of the Ministry of Health of Paraguay, Mr. Juan Estarribia. And representing the World Bank, Mr. Christian Herrera. Microphone, please. Microphone. Okay, good. Let's begin. Good afternoon. I'm very thankful. I'm very sorry, but we cannot hear him because the volume of his microphone is very low. But alguém tem que... Agora melhorou. Now it's better. Okay, so I'm very grateful to be here. We'll have a dialogue. Okay, now it's working. So we'll have a dialogue among us on a very essential topic, which is a workforce, employment, work conditions, and migration. For me, it's a pleasure to be here because I'm the Emerit Director of the European Observatory, and it's a pleasure and honor to have been invited together with Melita Jacob to learn from you. And watching your presentations, we saw that we have many similarities and also how we have so many differences and what the things that we can learn among each other. And with you, the Latin American, Caribbean countries, and also maybe that you can learn from us from on the other side of the pond in Europe. We have different contexts, but we have much to learn about our different strategies. On behalf of Hans Kluger, I would like to also thank you for this opportunity for our office to be here among you. Our topic for today is very clear. I'm not going to get into this slide. Please, next slide. There's a clicker. You can see that I'm not very good with technology. So I guess this is all very clear to you. These are the great challenges that we have, and that in the case of PHC become very important. People getting older, from one of each three family physicians has over 50 years old. We have the issue of migration, for example, internal migrations from rural areas to urban areas. We have professional burnout, and we have also citizens are have high expectations for PHC, but sometimes we do not have the capacity to respond to their needs. Mental health in our region, 1 in every 3 health professionals have symptoms of depression, and we've made a study, and these are the results that we had, and they are very concerning. And we must also remember that we have to see our specialties in many countries where we have physicians, such as in Spain and other countries. You have a ranking, and those that are the best students do not go to PHC because PHC is considered as a lesser specialty. So that is also something that we have to keep in mind. There are 2 landmarks that I will not talk about in depth, but I do want to talk about them because they are very important when organizing the different strategies to face these challenges that I've mentioned. This is a framework that was developed by my colleague here, Benjamin, who led this session and gave me the opportunity to speak. It's the PAHO framework that organizes its strategies in 5 categories for its governance, strengthen governance, develop. We have had an excellent panel earlier about the multidisciplinary teams. We have to strengthen and promote the development, and we have to have decent work conditions. We cannot talk about these frameworks if we're not going to use them to organize our debate. So the second thing framework I wanted to talk to you about when we organize our region, they seem different, but they are quite similar regarding the strategies below each of our issues and questions. So it's quite similar between our regions. They have developed this framework with their team. It talks about investment, and investment is a topic I would like to review because we spoke about it at the beginning of the meeting, because we need more investment in primary health care, in HR, human resources, as employment, and as return to society. And I wanted to talk more about economic policies and implementation, and to discuss finance for PHC, also the offer and employment. And here in Panama, when we were organizing this with Benjamin, we thought about dedicating ourselves here to the middle. It's retain and recruitment. Because we have these 3 important R's: to retain people with migration topics and work conditions, and recruit, or that is to attract professionals, because health jobs are not the most attractive for Generation Z. When we talk to the young people, when you talk about you have to work so many hours, it's such a continuous job. There are so many other jobs that pay better and are more attractive. So how can we attract young people to this profession? Topics about retainment and recruitment are very important for that. The other one is how to optimize performance. And this is a reskilling, or retraining. That's the 3rd R. How do we do that in the primary care? And of course, how do we plan these services? So we had 4 questions that we have established and for our debate. And these 4 questions reflect 4 strategies within this idea of retaining and recruiting and improving performance. The first one is related to migration. and to reduce migration. The second is how to push the professionals and went to in the zones that are more vulnerable or rural areas. And the second is regarding retaining and recruitment or work conditions, as wages and other incentives. And then the two last questions are regarding about the improving performance, and the skill mix topic might be a way to improve performance at the same time to reduce the pressure that we have because of the scarcity of HR in health. Because the problem that we've been thinking was the scarcity of health professionals. So these are some of the strategies to retain, to recruit, and to improve performance with a skill mix. And lastly, the digital solutions and AI. And this is our agency is a very important donor in the world for low-income countries that has been investing heavily in AI for this, so that because they believe that AI will meet the needs of many doctors in the clinics, because through AI people will be able to auto-diagnose, auto-treat themselves. But I think this is a bit radical and extremist. But of course, that the AI will reduce the need for physicians in the clinic, but what? So we must understand and start thinking. What do we think of? What is PHC for us? If this will be the case with AI. So the goal, as I said, is to learn from all of our experiences. So I will ask you to also contribute with your own experiences in a brief way, what your countries are doing. And so the idea is for us to share as much as possible on our experiences, lessons, in these 4 areas. I hope you agree with us. And before I'll pass the floor to our speakers, I would ask Benjamin to please make his comments, because I know he's been working on all of these areas. And so you were the one who organized this panel, so you are the one who gave yourself 5 minutes. I would give you more, but please you can contribute to our debate. Hello. Hello. Thank you very much, everyone. We have discussed many things with Joseph for us to reach this place. One of the things was if we should wear a tie or not. That was one of our topics. I think firstly, it's important for us to emphasize that what we're trying to encompass here today with this very selected group of speakers is something that is very broad. Each of our subtopics that we want to cover is a whole topic for a new panel. So what I would like to comment about our framework and our policy and for the 2030 agenda is that these topics, the same discussions that I had with Joseph is the discussion that the Ministries of Health also have. How can I cover all of these topics in such a short time? And I have 5 minutes here now. I think I still have a few more. But in this sense, from the perspective of the PAHO, to have a national HR policy for health is something important. But it doesn't have to be one specific policy, but it could be within a national health plan or a national health policy, as many countries have. In those countries where PAHO works, we have seen that only 6 countries in the region have a national HR policy with all of these elements that we mentioned and that are aligned, but that your member countries have agreed with and that are being implemented. 13 countries have it planned, but have not implemented it yet. And 4 countries do not have anything and it's not even in their plans to have such a policy. But why am I talking about this policy? Because it is a strategic framework to manage all the elements that we are talking about here, the 3 Rs that Joseph mentioned, the distribution, and it's also a tool for planning and projection of health professionals. And I want to emphasize in what Dr. Saavedra said on the first day, that when we are pushing an agenda to analyze the market in health, and that is something that we've been talking to with the banks, because you know of the importance of knowing in the market, not only in the public sector but also in the private sector. Especially in fragmented networks, as we see here. So we see that we must develop this in our region, and you can count on PAHO for that. And how do we call a policy as such? What does it mean? We saw that in many cases in the region, there was not a policy for HR, but it was just a project, and there was no definition, even at PAHO. So we gathered with the countries, and we decided on a concept and a description. And when we saw that in the past panel, we talked about the skill mix, or the expanded roles, and then the clinic becomes a career, and was mentioned by several of the countries here. Our colleague from Guyana also said it was something important, Paraguay as well. However, regulation is still a complex problem, and we have serious challenges that we do not see any advancements in. 90% of countries have implemented the anti-conception distribution through people for childbirth, but that is the doulas. But no. So I also want to talk about migration. We have several representatives of the Caribbean, and we have see their nurses leaving, especially both in and outside the region, the United Kingdom, Canada, United States, and we also see internal migrations. We see this a lot in Brazil and in Spain as well. And I want to emphasize how difficult it is for us to advance in that. We have countries of origin and countries of destination. And how can we talk about this? We have met with CARICOM countries, but we also have to talk to the destination countries. We've spoken to Dr. Padilla to talk about maybe a platform for ethical migration of health professionals. And with PAHO, we had a strategic orientation planning with several countries in Washington, including Spain and Portugal, Ireland, as destination countries, and United States and Canada too. And then here in Brazil, we also held an event that we coordinated jointly, in which we defined the roadmap for ethical migration. So this is what I want to leave this landmark, and what the countries have been doing and how difficult it is, but also the perspectives that we have. We always hear this topic of HR in every panel here, but that has to translate into concrete action. So thank you very much. And Joseph, the floor is yours.
Thank you very much. We are going to talk about this framework, and Javier is going to talk about it later on. We are talking, or have been talking, and we are not going anywhere if we don't pay very much attention and take care of all these tools that PAHO is offering for the different countries. So you have many tools already. So let's start in the area of migration. We have those push factors, jobs, careers, areas of work, the area of security, recognition. Sometimes it's not the money that's important, but the fact that you are recognized as a good professional. Let's not talk about problems because we know all about them. Let's talk about solutions. Our representative from Paraguay, you have already pointed out some important points. What do you do? How do you work with these push factors? Obrigado, Joseph. Boa tarde.
Trabajamos en tres.
We have three axes. It's important to think about the guidelines, the orientation, and the planning. The policy, the national policy of HR for health in 2020-2030 has allowed us to advance the needs and also the gaps we have in HR, especially in primary health care. So our plan has oriented what we have to do in terms of people training, and we are reducing inequalities in the different territories. Well, I understand what you're talking about. You are one of the 6 countries that we mentioned. Why don't we have more countries doing the same thing? This plan of HR in Paraguay. Well, it was a big challenge because it's a line of action in 3 governments. So we've been working for 15 years. So today we have a final product that is still ongoing. It's still a process. It's not a final product. But we have the roadmap, but it has been going on for 15 years. You mean 3 different governments? 3 different... No, I'm talking about 3 different presidents, 3 different politicians. In Paraguay, each government lasts 5 years. So we've been working for 15 years for the national policy of HR. Could it be quicker? Yeah. You can do it quickly, but each country does it its own way. If it takes 15 years, it takes 15 years. PAHO will follow this process. I'm not criticizing you. I'm just saying that this is a complex plan. For Mercosur, how long have you been working? 35 years. Another important point are the advances in job stability and also reorganizing the bonds, formalizing contracts, and also graduation of personnel that diminishes the turnover, mainly in certain territories. This policy strengthens the teams and also improves the PHC and also stops migration because you have better work conditions. You think that when you talk about labor stability, yeah, it's because of our roadmap and the strategy of PHC. We have the possibility of having economic benefits. Not for a long time. We offer also for each person that you are working near your territory. So you can work near your home. You don't have to migrate internally. You can migrate for a short time, but then we also offer locals or sites that are nearer to your original place of birth. So people go back for their homes. So this is good for the vacancies that we have. And it's very important because last year in September in Paraguay, we organized an event that we called the Week of Human Resources in the Health Area. This event that was that took place for the first time last year, and we are going to repeat it this year and the following also. The Ministry of Health designated a sector, several different sectors within the government to talk about HR. The Ministry of Finances, of Work, Labor Ministry. So different sectors were involved in this event. So it's not only during some period of time that we do that. We do that constantly. This is a product of the work we have been doing within technical concepts. We had different people cooperating with this week of HR, and we ended the week stronger. And we want to project these ideas for the future, and we want to have this event happening every year. Miss Juliette.
Faces a particular challenge with migration, and particularly you're the head nursing, director of the nursing services, head nurse, I don't know what's the exact title in your country, and have to face the problem of losing well-trained nurses to other parts of the region or elsewhere. How have you addressed that?
Okay, so good afternoon to everyone, and thank you for inviting St. Lucia to this discussion. Migration is a very critical issue for us in St. Lucia as well as the other Caribbean islands. As you mentioned, the higher resource countries are actually recruiting nurses from the Caribbean, and not only recruiting nurses, but recruiting experienced nurses. So we are faced with a situation where our more experienced nurses, which we need in the system to help strengthen the primary care system, we have them migrating. So a number of concerns are being raised, and before I say that, let me just say that in primary care, we do not have that much of an issue of the migration. It's more at the secondary care level. However, we do have a few of our primary care nurses, because of the terms of contract, what we have realized in the effort of strengthening primary care, we've had to employ nurses on a short-term basis. So as my colleague said, job security is very important for our nurses. And without job security, this is one of the push factors to the higher resource countries that can give them more lucrative packages. So we have been able in primary care to recruit additional nurses. Some of them may be novice nurses, as much as me, the experienced nurses, but we do not have a choice because we need to be able to get the nurses, the HR, to be able to run the services. So we've been able to recruit additional nurses. We also have been able to recruit what we call community health care workers that can assist us in reaching communities and reaching individuals within their homes to be able to do the follow-ups of patients, screening of patients, identifying new patients to be able to bring into care. So these are some of the strategies that we have employed. In addition to that, working conditions is also one of the push factors. So earlier in the discussions, we had the Smarting project. So through PAHO Smarting projects and the OECS regional project, we also have been able to improve our facilities and make them smarter. And in making them smarter, we have also enhanced the physical structure, making it more spacious, more comfortable for our nurses and other healthcare workers to work in.
Excellent. How important is flexibility, part-time work and so on for this particular profession? And sometimes in many countries it's very difficult to have flexible working conditions, and yet the evidence tells us, right, Benjamin, that flexibility, particularly in the nursing profession, is fundamental. How do you address that?
So it is quite we can be flexible, I must say, but not in all times, particularly in primary care where we operate, most of our primary care facilities operate on an 8 to 4:30 basis. Our polyclinics have extended hours up to midnight. So within primary care, it may not be that flexible, but within the polyclinics, we have nurses who work on a session basis. These are not nurses that are employed with the Ministry of Health, but they can come in and work certain hours. We also have nurses who, even if they are employed within the Ministry of Health, then they can come outside of their, on their vacation days or on their off days to come in for whether it is 4 hours or whether it is for the entire shift. So we can be flexible.
Immigration, sorry.
Yes, I think we have, particularly in primary care and the hospitals, we have seen a level of reduction, and that is specifically due to better pay, I should say, because they have been able to, through the government, have been able to increase the salaries of nurses, though, again, it does not match what the higher resource countries are giving, but it's able to, you know, kind of assist them financially. Yes.
That's what we learned very much with migration. It's not just the money, as we're saying, but all these various conditions.
Let me add one data.
Please.
In the Caribbean, we did a study on push factors, and the first one was salary potential. That was number one. The second one was work conditions. So what nurse is saying is perfectly right. And the third one, social instability, political and social instability. So those are push factors that we identified in the Caribbean.
It's interesting that sometimes one of the measures work very well is having nurses in hospitals for the health workers. It doesn't take that much resources to have a facility, so they can have their children in the hospital taken care of. It's very interesting how it's not just the salary, but it's working conditions and support. Let me move Javier Padilla, Secretary of State, Secretario de Estado en España, un gran conocedor de casi todos los...
And you can talk about any of the other themes. The theme of migration, primary care. And I would like to go to the next question, that is work conditions. But Spain exports and imports personnel. We were working with PAHO in this platform. You import people from Santa Lucia and from the Caribbean and from Latin America. Yes. The professionals come from the Spanish-speaking countries mainly and go to Spain. In Spain, the perception of the population is that we have foreign professionals like physicians. We have 800 doctors that leave Spain, but 8,000 come to Spain. I would like to say that in Spain, we don't have a procedure to capture professionals from migration. This is important. From an ethical perspective, we don't want to favor the brain drain from the countries that really form those people, these professionals in the health area. I have worked with PAHO, and I think that first thing that is important is the data. We had different ministries from the Americas that said that it would be useful to have the information how many professionals in different categories are working in Spain or other countries, to see if it would make sense for them to have a program for people to return to their countries of origin. And the other element has to do with the capacity building of these personnel. What would be the habits that would make sense so that we can have the circulation of professional people in a practical way that would favor people to stay in a place and another place for a period of time. But if we link these elements to the data we have competition, and we have an ethical landmark and the need to adjust the supply and the demand of the system so that you don't have so much migration. Migration is a reality and it's a right, But we must try to have a plan that will retain these people in their countries of origin. So what is the strategy of planning for HR? Yes, it's to strengthen the information system and human resources in the area of health, not only internally, but also externally. The lack of data we see in the US and in Canada, that they have private corporations that recruit people, especially in the Caribbean, and it doesn't go via any government. It's private corporations that do that, and it's very difficult to reach them. Now let's talk about the ethical code. So that those corporations really are damaging. And we have migration within the region, like in Chile, is a destination country nowadays. And you have to look at Chile under this perspective. Yeah. If we have time, I would like you to contribute also to these questions. Now let's go to the second one. That is a continuation, a follow-up of the first one, is the work conditions and also the elements of how can we retain them, and also how to recruit mainly the young people. The people in the health area are not so young anymore, mainly in the primary care area. The first action that we did to improve retention has to do with the time of work. Temporality is a problem within the structure in Spain, especially in the health area. We have to have job stabilization and also of their specialization. So you end up your specialization process like a family medical doctor, and then a few years he would have very precarious contracts. Now you can graduate and you can have a contract in a region in Spain for 3 years. So you have stability in the same city where you graduated. And also the work conditions. We are working with the unions in Spain to elaborate regulation for that, so that people work for 24 hours and then they have days off or a day off, 48-24, and in Europe it's 45 hours. And we have to try to incorporate research also within an element to develop the professionals, and also to establish measures that have to do with the professional life, the end and the beginning of the professional life, so that we can benefit the professionals that want to live their professional lives. We have done that with the family doctors because there was a deficit, a lack, a gap in this area. And the young people will need lasting contracts that are very clear. A family doctor with a certain expertise doesn't want to do primary care, but he can go to a hospital or do research, so you can incorporate some elements in his, and that's why they have mental problems sometimes and depression, and we want to eliminate that and have more hours off, and you work and then you have different shifts that are regulated. That's interesting, isn't it? we have to be more flexible. That's what I was talking about. You have to be more flexible. And I have another question. Will it solve the problem that we don't have doctors and they don't want to work with primary care?
And regarding also the work conditions and how to attract them. Yeah, in Spain compared to other European countries, we see that not only for primary care but for health professions, they reject or they do not want to graduate in these areas. It's lower than in other countries, but we still haven't seen this wave that we see in other countries of high rejection. However, regarding PHC, there is a recognition, is a symbol that PHC is important because everything starts there. We have to have actions there because that's where everything where care is coordinated. But it's also important to be aware that PHC represents values that are not the hegemonic values, prevalent values. Nobody wants to be 15 years in the same job. Nobody wants to. We have the concept of community is being replaced. When you have this new world, with the Renaissance vision of being have a generic specialization is not in vogue right now. So, for example, I think that the capitative distribution has to be related to the wages, and also favor professionals can develop their expertise and their interests, because this is also related to to AI and other digital transformations, and something that is we've seen in Spain notably is something that is related to workload and times, because we had shifts where people worked every afternoon from Monday to Friday. Nobody wants that anymore. Or even if you could want to offer that as a system, if you cannot cover all the shifts, then the power is in you have to adapt the offer of these. Yes. Otherwise, the people won't come. So you have to have mixed shifts, a little bit in the morning, a little bit in the afternoon to work, as that also can retain people. That is so interesting. Yes, especially when we talk about empowerment, when to give them the tools to be able to work according to their interests and with recognition. Because when you talk about PHC, we say it's the core and the base of the system, and in reality, that's not what really happens. Now, Christian, in Chile, we've learned that you have great PHC in Chile. So the bank, and I think the perspective of the bank is very important as well. This of several sectors when we talk about the economy and employment and work conditions. How is it done in the health sector compared to other areas? Are we really competitive in order to attract the young professionals to our world? Thank you very much. Yes, very interesting, and it's a priority for us as the World Bank. And we have a more broad perspective that encompasses PHC, but the whole health sector as well. And as the World Bank, our president gave us a cross-cutting goal to work for more and better jobs. And this priority has defined 5 scopes where we can generate more jobs. And one of these scopes is the health sector. So he gave us this mission and task to convince those that are not convinced yet, because everyone here understands, and we do not have to convince ourselves that the workforce and professionals in health and PHC and in the sector in general are a priority. We know that that is important, but we have people that we still need to convince, and that is the economy, the economic sectors, the finance ministry, the economy ministry, the banks. How do we tell that minister from the sector of finance and economy that this is important? And one of the tools that might help us is to tell them that in the health sector, you have one of the main sectors where you can create new jobs, and every minister of the economy and finance wants to create new jobs in their country and increase the well-being of the population. So this is a very clear path on how to create new jobs. We have several colleagues here who manage projects in several countries, and through these projects that are already being implemented, they created 600 jobs in PHC through the strengthening of the first level care units. So that means that we can create new jobs in the sector. You have with quality, even if we have criticism, but still, for a finance minister is very attractive. And as Minister Aguilera from Chile told me yesterday during lunch, because we had been in Chile together, she told us that in health industry is the largest employer in Chile. There is no other sector that creates as many jobs as the health industry, and that is growing. And that is something that us as the World Bank want to expand this to the whole region, because that is probably the same case in other countries. We are the top 3 sector is a better workforce. It's a better human capital with more productivity. And that is something they will always agree upon, and that is what they want. With a better health system, better workers, more equity, that will create a more productive workforce that will have less leaves, that will have less days off, and because they need the conditions to work better, to be better, and that is very important for the Minister of Finance and for the population to be healthy with new jobs. How much we can bring as gains with less mortality or with less medical leaves, and how would that impact the economy? And we want to deliver numbers to the ministers in finance and economy. Yes, I like that very much. Of course, the first part is the job creation. Do you know why the investment bank was created in Europe? Its core was to create jobs. So this is fascinating. Second, it was a black hole, because the finance ministers always say, you are a black hole. What do you do with this money? But the third item, and I want your opinion on this, is that health is wealth. That human capital is, the better the human capital, the more wealth you have. So why is it so difficult to convince the ministers of the economy of this? How long have you been taken to have these numbers? I can say that not so much time. I know that's been taking a long time. In the European and in the Caribbean and Latin America, not as many years as Europe, but we are trying to do it better and more. We're working with the countries with coherent data and also with new perspectives, not working on only one area. We have another example. For example, we were able to estimate the impact not only on the population's health, but also on the economy of a new shock that can reach the region. We've been working together with PAHO and the World Bank, and we estimated how much would it cost to the economy in terms of the GDP if we had a new epidemic or new shock. And so we'll deliver numbers to the governments and the finance ministries. So there are different perspectives that we can work on, but the workforce and job creation is a very interesting perspective that delivers more arguments for this discussion. I think this is very clear. We have to study, we have to learn about the economy, and so we can have more opportunities for investment in our HR and the industry.
Welcome. I would like I think that everybody would like to thank Brazil for this great conference. You are the only Brazilian in the panel. Thank you very much. We are very much impressed. We went to a field visit yesterday, and we were very impressed. There is an important debate in this country about the health sector and the work conditions, and I was very much impressed with the enthusiasm you have for primary health care. We saw a reality yesterday that was very exciting for all of us. What do you do that you are so enthusiastic about everything? Good afternoon. Hi, everybody. First of all, it's a pleasure to be here with you in this plenary session with so many people that I know and others I don't. And I'm feeling at home, although I am not from Rio, but I'm talking about Brazil. I am Brazilian. And this is a snapshot of our country, our people, that reflects in primary health care. It's the care that is delivered to everybody in this country, irrespective where they are located. For us, we have an enormous number, more than 3 million workers, and we have our own challenges, and territorial inequalities is one of the challenges. When we think about the medical profession, in Brazil, we had 1.8 medical doctors per inhabitant in 2013, and now we have 2.98. We are nearer the goal, but we still face many challenges. The professional of medicine is we lack professionals in the area of medicine, but we also lack dentists and nurses. Depending on the rural area of Brazil, we don't have enough dentists. But when we think about the medical profession, we have been for 10 years implementing a program that we call More Doctors. It's been around for 10 years. So as for work conditions, our program also has something to teach you, and I have some things to say about what we have been doing that impact the work conditions. And we are able to use that as a model for the other workers in primary care. When we think about work conditions, we think about wages, we think about infrastructure that impact the work conditions. In 2025, we had a survey that we have 26,000 doctors that are linked to the program More Doctors, and we had a survey of satisfaction of these 20,000 professions. The level of satisfaction they had vis-a-vis the program More Doctors. When we observe work conditions, they talk about that very much. There is a positive evaluation as to adequate infrastructure. 57 say that access to medication and input is something that also lead them to satisfaction. But also there are other issues that we have to understand and think about how to translate that into other countries and other workers in Brazil. Migration is structural, it's not individual. So it's not worth it doing it individually. We have a group of workers, and More Doctors was able to do that. And this is a great value of satisfaction for the medical doctors, because we want them to retain them. They can stay for 4 years, and they can extend that to more 4 years, and they receive bonus as they evolve and stay in a place for more years, they have more bonuses. The salary grows. And there are other bonuses also that they include. That's not only money, as they stay longer in a place. More doctors, it's also to capacity building for those doctors. As they stay longer, they learn more. They can have a master's course, a PhD course, and other studies that they can carry out. So thinking about the work conditions, those are winners that we have identified in Brazil in the More Doctors program. The effect is such that the doctors themselves recognize the value and they are staying longer in those areas. Well, I think there is a consensus as for these measures that seem to work. As for primary health care, is it are young doctors attracted to primary care? What do you do to attract them, the young doctors, to primary health care? Well, More Doctors was created as an offer of bringing more doctors that graduated for primary health care, but in the last few years they also offer places for expert doctors. We are not only at primary health care, but it started with primary health care mainly, but now we are going to other specialties also. But what we see in the More Doctors program that has made it grow, it's also the fact that they have medical residents. Now we have more doctors that are interested in doing family and community medicine because they can study in the program more doctors. The job places for family doctors has doubled due to the fact that they can study during the residency. And for more than 20 years, we have been working primary health care as the main axis of our program. From the first semester to the last semester, all the doctors are circulating in the area of primary health care. So they go through this primary health care and they stay there from the time they graduate up to the residency. Well, this is a good information that we need more information to disseminate these ideas of the More Doctor program. We are running late as always. We had an hour and a half, but we started half an hour late. So I think that we can stay a bit longer. Let's have 15 minutes for the last questions for everybody. Let's talk about the third question or the third area, that the skill mix. Besides the medical doctors, which are the other professionals that that we need in our programs? Let's say pharmacists, dentists, nurses, of course. So under the perspective of human resources in health, how can we change the skill mix and then solve our problems? You have mentioned in the other session the political economy, the complexity of the different disciplines, the doctors that feel threatened by other professionals that are taking their jobs. When we talk about skill mix, we think about transformation. What is your experience in Paraguay? In Paraguay, we work with the strengthening of focusing in the team, in an interprofessional team or multi-professional team with functions that are well defined. We want nurses to be in the limelight also, so that we can have a shared model of healthcare. So we can go on training these people, especially in the area of chronic patients. And the doctors are for only the more complex cases. So this has strengthened the continuity of our programs and improved our healthcare all over Paraguay. And we also have the whole population that has different teams that are multi-professional teams that then can have people with chronic diseases can be treated by the medical doctors. And we have a periodic control that ensures the continuity of their treatment. And we have family doctors. And we also incorporated management of care with different tools. We use registration with networks that made easier the control of this sector. We have clinics and doctors that strengthen the care and impacted our healthcare. For chronic disease patients, what we wanted and we still want is that the team of family healthcare has the same goal. Everybody has the same goal. Those multidisciplinary teams work, but there are problems of hierarchy sometimes. There are problems of acceptance, of accepting the other professionals. How does it work? Do they work in harmony? Is everything perfect? There's no fighting? What we want is an intersectorial sort of work. And the goal is the user. We are centered in the user and in the communities. So the whole team is obliged to work in an organized system where there is no hierarchy. Any member of the team can make decisions, and then we have a consensus for working in a team. We can learn a lot from you, I realize now. What's important in this skill mix is to include the patient and for their own treatment. The patient and the community. They are also the main characters for the team, the health team. So the patients accept all the team, all the people involved in healthcare.
The role of nurses. Are we taking advantage of their skills, their effectiveness? When you look at the evidence, patients prefer nursing in certain areas. For chronic care, for some prescription, work much better with nurses than with doctors. How do you handle that in your country?
Yes. So.
Yeah.
Yes. So we do have various categories of nurses in St. Lucia. We have the advanced practice nurses, who are the family nurse practitioners, and psychiatric nurse practitioners. So this group of nurses do assist in the role of the physician. So they can diagnose and they can write prescriptions. So that assists
The
our
physicians accept nurses writing prescriptions?
Yes, yes. Our advanced nurses, they do write prescriptions and they can diagnose. So that also relieves the pressure of our primary care physicians because they would not have to perform that role. And of course, it is greater access for the patients. And you speak right. Many times, the clients rather see the nurse practitioners than the physicians. Why? Because they do take more time to listen to the patient.
More empathic?
That's right, and to be able to adequately diagnose and prescribe whatever medications they may need. So we do have.
Care or for all kinds of conditions that they operate these nurse
It's for
practitioners?
all types of conditions.
All types.
However, the nurse practitioners do need to consult with the primary care physician on difficult situations or diagnosis.
What are the legal implications? There's been a lot of debate in our countries about the legal implications if a nurse practitioner makes a mistake, fails to consult the doctor. How do you handle that?
So they are covered by legislation. So it is in our Nurses and Midwifery Act that
So
they
feel
can
protected
prescribe.
because nurses
They feel
sometimes don't want to do that because of the legal. So you pass legislation to protect.
legislation, yes, we do have legislation in place for this, yes. One of the things that also happen is in terms of our community health nurses, they can also order lab investigations for patients. So it does not necessarily have to be the physician to do that. Whilst they may not be able to review the results and make decisions and diagnose, but they can refer clients. And this happens a lot with our diabetes and hypertension clients, where they are seen. Annually, they need to be able to do their lab investigations. And so a community health nurse can refer those clients to do the lab investigations, get the results, and then refer them to the family nurse practitioner or the physician as required. So what we have found is that those roles have really reduced the pressures on our primary care physicians.
Well, there's a lot we can learn from Santa Lucia. I wish you publish all that, well, I'm sure, through you, Benjamin, because for this region and my region, that's absolutely smashing. Well done. Congratulations for that.
Thank you. Can I also
Please,
add, one of the other things that we spoke about it from yesterday in terms of our mental health program, what we have also done with the support of PAO is to actually train our primary care physicians and nurses to be able to assist with mental health services in the community. So we are going through that training of the MHGAP training, psychological support, psychosocial
To doctors,
support.
or you are bringing psychologists as well in the skill mix?
We do not have psychologists in the skill mix. We only have one psychiatrist in the community that serves a population of 180,000 persons. So it's very crucial and very essential that we can provide additional training to our primary care clinicians so they can give support and really strengthen community mental health services.
Excellent. Thank you very much, Juliet. Javier, ¿nos cuentas un poquito la situación en España?
Well, first of all, I would like to comment that when you were making the question and talking about the perspective in face of a situation of deficit of medical professionals, yeah, I did it on purpose, that we would need to use that to redistribute tasks. However, I think that from this perspective, the only possible answer for this is a conflict. It's a conflict that will exist, but that I think we have to put it on a new framework. Like as public managers and the governments, we should try that all workers in the health sector should do and carry out all their expertise and in the best ways possible. And in a longitudinal perspective, I believe that the training of nurses is worse today than it was 20 years ago. So if we improve that, maybe they have more competencies and they can apply them better. And I think we should also see that we have these conflicts and that they exist. I think all professional categories can identify any other category that they envy or that they are jealous of because of their competencies, but also internally, the radiologist doesn't want the family physician to see the x-ray in the PHC, but also the anesthesiologist doesn't want the endoscopy doctor to do the anesthesia. So we see all of this, all these conflicts. Also, the clinic, the physicians, the nurses there have to do the IVs, and the doctors don't want that. So the best way to manage this is advancing, but the best with the best evidence available, but always emphasizing that what we have to focus is on the improvement of the patient's health, and we have to see this redistribution of skills and tasks that will not impact negatively the results. It has to improve, and we address this on the one hand, looking at each category that it must develop, but not just extrapolating the physician's tasks, but in other ways. If you have the clinic that has a specific development that is different in psychology, it's okay. So that's the first thing we must identify. And the second thing is that there are a few scopes that are conflict scopes that must be decided with dialogue among everyone, but it's the legislator that will have to solve that, and that regards prescription by nurses. In Spain, we're seeing that we have the indication with very protocols, but it's not a final character. Most times it still has to be approved by the doctors. So we are trying to change the legislation to give this faculty to the nurses so that within their competencies they are able to do this prescription. But what does that mean, people ask? Because nobody thinks that maybe a dentist can do prescriptions, but they will not prescribe something that is not under their scope. Of course, the nurses will also prescribe under their competencies. And we have to talk also about AI. There are professionals that assume their functions better. They trust more AI than human intelligence. And sometimes when we have occupation, they're going to compete more with AI than with human intelligence. So we have to think about this, one versus the other. And one of the things about redistribution of competencies is to think of end result tasks and functions, not putting more intermediaries. They would not have tasks that still have to be validated by a doctor. For example, they have to be an end task. Now that does not need more validations. But we see that there are elements within the system that makes us redefine the functions and jobs. For example, in PHC in Spain, we've been working a document about recommendations in Spain to improve longitudinality and the continuity of care. And one of the things that we have been analyzing is that you shouldn't think longitudinality regarding the patient and doctor, but also the whole teams in PHC that have to look at these longitudinally. When you have the values of PHC, we will also redefine the delivery of the profession. You see that Javier has provoked me because I have a very Eurocentric view with shifting tasks. But Evelyn, what is the perspective from Brazil with all this skill mix and the clinics?
To be very brief, I think there is a characteristic that's very important in Brazil for primary health care, because it began with a nursing team. The first issue is that the process of the regulation of jobs in Brazil is decentralized. So each category of profession can determine its own acting area. And the state, the government has a role of dealing with each different entity. And when we look at primary care, and the team of nurses and the nurse in Brazil, primary care comes about due to the actions of the nurses. So they are very autonomous to produce care in our country. When we think about the advanced practices of nursing in other countries, they are different in Brazil because the nurses in Brazil do much more than nurses in other countries, or other countries are considering advanced practices. We have been doing them for a long time. We still have a process of forming the nurses in Brazil. Now they can use IDUs. They can place IDUs in women in the family healthcare units, and the state is responsible for the process of teaching these nurses, and when they graduate they can use those contraceptives in clinics. So we allow for nurses in Brazil to care women, children, and also chronic conditions in general. So I think that in primary healthcare is the place where we have advanced the most, and this is a result of our own history. And we have another characteristic, that is the health community agents. Now they are technicians in the area of health, so it expanded their scope of practice. This technician, as a community health agent, he can develop activities that they didn't. Can go to households, measuring temperature, glycemic level, high blood pressure or blood pressure in general. So the following of diabetes, for instance, is done by those agents. So this is very recent in Brazil. And we have almost 300,000 community health agents. And I think those are two characteristics in the terms of novelty in the scope of our teams. What we call the minimum team, that is the community agent and the nurse. What about community agents? Brazil has told us about the good practices to be used. You use this information. How can we help the member states to learn with those experiences? Well, part of our work at PAHO is to exchange lessons learned with other countries and look for the best practices. I would like to talk about attraction, because this is very important when you talk about the young people being attracted to primary health care. Christian talked about Chile, and Brazil also mentioned. 2 weeks ago, we published a study that we carried out in Mexico at the University of Mexico with all the associations of healthcare and primary healthcare in Latin America. Those community and family doctors are not where they should be, and they are not doing what they should be doing. So we have to follow up this person that decided to be a family doctor, and all of a sudden, we don't know why, they end up by working in other areas. And this is a problem. Last question. I would like you to talk about AI, and then what is your role? Javier was saying that AI is better than the human intelligence. What about the bank? How are you working in this area of AI? Does it solve all the problems? The first thing to say is that in the healthcare area, in our projects, all the projects in the region, we have a component of digital health. It can be telemedicine, it can be electronic clinic, something linked to technology. AI is the most recent one. So I think it's important to comment that, because that's the practice you must all have in your own jobs. And we have to link that with what I said in the beginning. The generation of jobs in the area of health have also to do with the support area, let's say, the deliver of services with innovation, and digital health generates more jobs, new jobs, and also expands the health system and the primary care system also. So we must have a different look, a more broader look. In Costa Rica, we are supporting this region in the area of social security to machine learning, AI, predictive methods. They have information and very good data that have been collected for a long time. Everything is digitalized. So what we want to do is to get this wealth of information and use that with AI to say that in 6 months there is a probability of hypertension becoming an issue, and so on and so forth. The evaluation of imaging, of radiography, all the information that have different characteristics in the area of the social area, demographic area, and health area. So we want to deliver this information to the team of primary health care so that they can do the intervention work. A clear example of how this can help. And also, you also free people from very routine tasks and to dedicate more time to something that technology cannot substitute. For instance, a household visit. A nurse, a technician has to go to the home of the patient. But if the person has more time, they will be able to do more visits. So those are the big advantages, the major advantages. We have to do it, but we have to do it well so that it can we have to generate the landmarks of governance, not only via legislation, but also we have to help not only the public area, but also the private area too. Governance has to be applied everywhere. We have seen countries where there is some resistance, and then there are problems as to what is being done. We have to develop all kinds of technologies. But there are risks. But the potential is enormous. So also, all the countries should work over that. I wanted to hear Christian to say how we can get the help from the World Bank. I like the fact that you talked about risk, and those of you, and I was there, saw the information system yesterday at the center, and when what the patients do when there are heat waves and so on and so forth. If we apply that of risk certification, we can work better. We can classify the different risks. Are we going to gain something within AI that will help primary health care to identify the patients that will suffer from climate changes?
Well, within the hour and a half that we promised, Let's have a few questions, and then at the end I'm going to make a really difficult questions to our speakers, but you'll have only 30 seconds to answer. We know we have limited political capital, and you know this very well because you work with politicians. It's very limited for them to, because they only want to implement one or two reforms at a time, because we always want to say we want to do this, we have reports, we have strategies. Yeah, that's great, but Monday morning they are only able to do one thing. So from everything we've heard here, please, I want you to declare one strategy that you believe to be the one that must be done Monday morning. The first one, the priority. That I'm not going to cheat. The chicks, I would like to ask for a few contributions, please, from the audience. Please, don't leave me alone. Just contribute. Thank you. I'll invite you to a caipirinha later for being the first. Hello, I'm from Bolivia, from the health system. Many times we have the role of professionals, especially in nursing, in which we have a few documents and for prescription, and we do this by necessity, but others do it by strategy to optimize the operations of their interdisciplinary teams. And I would like to ask our St. Lucia colleague, how did you overcome these barriers? Because we've seen that the role in nursing is basically done in more specialized areas like oncology and instrumentalization. And also I want to ask, briefly short, from the World Bank colleague, I would like to ask him about the topic of migration, that the migration that is not taken advantage of. Like, for example, we have the Uberization of professions, a precarization of professions in specific cities that are not enjoyed as much. Okay, we would like not only questions but also contributions, please. What are your countries doing and what do you want to share with us here, please? Good afternoon. Thank you to our speakers, and thank you for your moderation. That is very dynamic. I know that we have our time is short. I'm Hernan Rodriguez from the Health Services here in Brazil. Just a brief comment before my question. We know that we have a gap, and Benjamin mentioned it, and in our analysis, we know that we have this gap in medical and nursing human resources, but also other HR personnel like pharmacists and dentists and psychologists. But the concentration of the personnel in areas like large cities and more urban areas, we want them to go to more remote areas. But I always think that's not only a solution for the health sector, but how does this articulate with other sectors so that the well-being of that person that is going to move, for example, if they have families, are there going to be schools for their children, etc. We have to think of the well-being of the professional, and I want to know if there are countries working on this as well. Okay, I'll give you this one. Okay, more issues, more questions. Thank you. Here we go. Another question. On May 21st, I left the Palais de la Nation in the night because we who believed in a multilateral world, we approved the ethical code for health professionals. I was representing Brazil at the time. We had the speech that it wasn't fair for poor to subsidize the rich. Was it worth it? Who would like to answer that one? It's a difficult question. Thank you. Thank you very much for bringing that. Another question? Okay, here. Thank you.
Congratulations to the panel. Excellent moderation and really wonderful sharing as well. I'm Edwin Velastig, Sub-Regional Advisor for Human Resources in Health at the Sub-Regional Office in Barbados for PAHO. I just wanted to share, I wanted just to pick up on what our principal nursing officers from St. Lucia spoke about in terms of advanced practice nursing. Professor, you also mentioned about the sharing more information. So just wanted to share this as part of our sub-regional work at PAHU. We recently did a study on advanced practice nursing, particularly on the regulatory framework of the programs that exist in the Caribbean. And we're very happy to know that to share with you that we do have a draft policy brief on that already. And so we'd be happy to share once that is finalized. And also, we have a draft Caribbean action plan for the migration and mobility of health workers in the Caribbean. And once that goes through the review process, we'd be very, very happy to share with everyone in this forum. Thank you.
Very, very thankful for that. We need kinds of very practical studies. I think we should move, if there's nobody else who wants to speak, we need to go to the visit. Can I start with you? ¿Puedo empezar? Perdona, he pasado ahora al
Okay, now back to English. Do you think, Benjamin, that you can talk about the topic of the support of housing and schooling and yes, retaining strategies for health professionals in remote areas? Yes. I think, Wilma, you can solve a lot in Brazil because Brazil has a very interesting experience on this that was already mentioned. What are the elements that are part of this strategy? We have to link practice with the learning and capacity building and training, for example, because they are creating programs that provide services for the population, but they also provide education and training courses for professionals here in Brazil, or maybe medical residencies that are also delivering the practice and giving credit for residency programs. So this is an essential point. And also the flexibilization of times and shifts that my colleagues mentioned, that is to have the possibility that if they move alone, maybe they can go back to their city of origin and be with their families once in a while, or because sometimes there are very remote places where they cannot take their family, but also, so maybe we have to have some program like that. But also about intersectoriality, I think we have to have an intersectorial investment to have for schooling, to have the internet, to have courses and professional development projects. So these are only a few examples, and we have some other examples in Spain and others in the region, but well, yeah, but it varies according to the countries.
Your boss at the country, don't worry. It's just Chatham House rules here. Whatever priority you put on the table.
We are on the virtual platform. Okay, so just to answer the question from the colleague in terms of the barriers, having nurses prescribe, diagnose and prescribe has been there for a very long time. I think even before my time when I came into primary care. So what I know for the discussions I've had with the older nurses is that there was a lot of pushing against this from the physicians. Because of course, as physicians, you know, this is the role of the physician and it cannot be the role of the nurse. So I know there was a lot of pushback from what was discussed, but eventually they were able to come up with the list of drugs that these practitioners can prescribe, and also to ensure that there is consultation with the physician before any major decisions are made or for complicated cases. Yeah?
Your priority?
What I can say, which I can speak very confidently of, is with the comeback of our new administration in government, our Prime Minister has changed the nomenclature of our ministry to the Ministry of Health, Wellness, and Nutrition, with a specific focus being on nutrition to be able to enhance the lifestyles of our population in terms of the eating habits, because as we know, eating nutritiously is very important in terms of reducing the burden of NCDs. So this, I know for sure, is going to be a focus of our government, and I know he's going to put resources in there because the nutrition team is extremely small, so I know for sure there's going to be resources in there to be able to push that agenda.
Acting on determinants. Excellent. En el campo de recursos humanos, Javier, una prioridad. No estemos en España.
We're talking about their priorities in Spain, but yeah. Yeah, from one day to the other, we could change something. Is that the nurses with their community and families expertise should stay in PCH, and that is something we are working on because for many years we trained specialized expert nurses on family and community health, and they don't stay there. They go to the hospital, and that is a brain drain, and we miss these talents within our system because we train these talents and then we expel them from where we need them most.
What is your priority under the work conditions? What can you say about it? Migration and the priority for me I like data very much. I love data. So I think that the basis for that is to have good information that is sustainable over time about human resources in general and in details. So the priority is to generate that in a sustainable way, because then you have information about everything. Everything you want to do needs information, needs data. So we have migration that is not well used. We must see how the professionals move, where they go, where would they like to go. So that's my idea. What about you? What's your priority? My priority would be to use the tools we already have. We have data, we have information, and we should be able to obtain human resources. It should be not only money, but also use the personnel that we have to improve the thing. Improvement for working conditions without listening and also opening a dialogue. Thank you very much for your participation. I was just 5 minutes late, 1 hour, 35 minutes. Thank you from the audience for your participation, and mainly thank you, panelists, for your brilliant explanations. Thank you.
Encerramos o segundo dia.
Ladies and gentlemen, we're ending our second day. We thank you for your presence, and we'll see you tomorrow at 8:30 in the morning for our last day of event. Thank you very much.
Também do passeio que a gente vai ter agora, o ponto de encontro será no foyer do Centro Cultural.